Yeah, we can see your desktop. Yeah, we can see your PowerPoint.
Pablo, could you share the YouTube link? There was a question about it in the chat group.
Yeah, yeah.
It's okay.
It's on YouTube, Sanjeeva. It's live on YouTube.
Yeah, could we just share the link on the, Pablo, are you able to share it? Or?
Okay. Can I share a video in order to check if I can?
I think it's already 12 time,
Okay.
and we have to proceed because I'm going to give a small introduction and then I'll
Sure.
give over to the moderator.
Great,
Yeah. Yeah.
Excellent.
Yeah, Pablo, you are with us?
Yes,
Pablo is there.
I was setting up the YouTube channel.
Okay.
It was in the chat. It's live.
We are going to, I'm going to share my screen. I have nothing on the screen. I'm just talking. And I'm going to start, okay, everybody?
Yeah. Yeah, sure.
Yeah.
Well, good afternoon, everybody. Good morning and good evening. Wherever you are, we would like, on behalf of the World Federation Neuroanatomy Committee, Professor Benish and myself as a co-chair of this committee would like to extend our invitation to all of you. We appreciate your contribution. A special thanks to the members of this committee that were very active and the invited faculties. And we will continue to proceed with our mandate to move from textbook anatomy to a dynamic functional anatomy to bridge the gap to clinical practice. So this is the mode we are using and adopted and have received a good appeal from your feedback. We reviewed your feedback, all of you, and we were very active and we were happy to adopt many of these recommendations you made, but we cannot be purely a textbook in neuroanatomy. This is for basic science. We are in clinical science. And without further ado, I'm going to extend the appreciation as well to the World Federation leadership and to all societies, organizations, and subgroups to their contribution and support to this functionality that last time recruited 7,000 attendees as a registrant. So I will give the microphone to Professor Ramesh, who is going to chair with Professor Aipe Sherian and Professor Kasadi that session on vascular, mainly the first day. The second day will be on orbital anatomy and intervention and skull-based surgery. Professor Ramesh?
Thank you. Thank you, Imad. We're all looking forward to a great session today. The topics looks really exciting. And we've got a great lineup of speakers, all well-known experts in their fields. I'm going to start with Professor Ramesh Kyrillos, who is now joining us from Singapore. He's going to talk about the vascular anatomy of the anterior, middle, cerebral, and posterior cranial base, which is so clearly important for all of us to deal with any vascular cases. So, Ramesh, all to you. The rules are clear: 20 minutes discussion and 5 minutes for discussion. 20 minutes for presentation and 5 minutes for discussion.
Right. Thank you very much, Ramesh. Thank you very much, everyone.
For the registrant, they have to put their question on chat. So the moderator will be the sole one who will select from. Thank you.
Thank you.
Thank you very much. I'll cover the anatomical talk. I cannot advance.
Ramesh, you must click with your mouse, if you don't mind, on the screen. That's it.
First, I acknowledge Professor Roten's slides that was donated to us, which I'm going to use for this talk, which is mainly anatomical landmark. I will concentrate due to the time on the carotid and relationship to the skull base and the vertebrovascular junction, and the connection between them is really about intraoperative landmarks and orientation, and we'll use the floor of the sphenoid sinus as I will show you subsequently. And now what is important in anatomy is that we have endoscopic skull base, and we have to correlate the view from intracranial and from the skull base to the endoscopic view, which is a bit demanding. So when we start, this is the workhorse for endoscopic skull-base surgery, we go through the sphenoid sinus. Once we enter there, we start to get landmarks, the optic and the carotid impression, and it's mainly to find the OCR opticocarotid recesses, which is the impression between the angles between the carotid, we can see here, and the lateral one, which is well aerated in this specimen, and it's where the optic, the strut for the anterior clinoid is. But what is important is the medial clinoid. This is an area above the tuberculum celli, which is here, above the middle clinoid, and it's the corridor to enter the carotid as the supraclinoid. So the talk will go through the carotid artery, as you can see, and its relationship to the clivus and the skull base from the anterior fossa down to the middle fossa. So if you concentrate on this view, which be important to know, forget the numbers, but we will use it for clarifications. The parapharyngeal carotid enters the petrous bone through the carotid canal, has a horizontal part and a vertical part. This is the petrous carotid. It passes around here, which is the foramen lacerum, and you correlate it with the angiogram. First, you find your ophthalmic artery, and then you can correlate the carotid. The fifth nerve is straddling it in 45 degrees with V2 around this vertical part. Then we have another part, which is the fourth segment in this, and at the apex is the meningohypophyseal trunk. So the pituitary gland lies here. And then we have the carotid siphon. And if you concentrate on the number 3, number 4, and number 5, this is numbers means nothing, but just concentrate, because this is where the cavernous sinus will start. The cavernous sinus starts above the V2, so most of the vertical and the vertical part, the C4, and is the all cavernous segment, and it ends where the fibrous ring is here. But then when endoscopy came, we renamed 2 segments. This vertical part to be called the paraclival carotid, while the siphon here is called paracellar carotid. And we don't see this from that view. In fact, this is what you see. So this is the paraclival carotid. This is the paracellar, and this is the entrance. The intercarotid distance is narrowest usually at this point. This is the point that is potential for vascular injury during endoscopy. And as you can see, the carotid is in line with the pterygoid plate. This is in the lateral view, and we can see well-aerated sinus, and you can see the carotid siphon. So this is the paracellar carotid. The paraclival is more posterior. Now, for the other segment, if we look upwards, then we can start to see this segment that is not obvious to us because it's tucked away before where the pituitary is. And you can see here there's the inferior hypophyseal artery because the meningohypophyseal trunk is located here. Now we look from the above, so this is the view, this is the top, the feet is down here. And we have to appreciate that the paracellar carotid is more prominent, while more posteriorly is the paraclival. So they are not in the same line, as you can see here on the lateral view of an angiogram. Now, if you look from inside and to try to correlate, this is the middle fossa on the right side. So to orientate you, this is the optic nerve, carotid. So this is the top, this is the posterior. And then if we peel, we start to get the Meckel's cave and the cavernous sinus, which they are both potentially the same place here. So this is the cavernous sinus, and anatomically, the cavernous sinus starts above V2, although there is an extension, as you can see here. Once we cut the superior petrosal, we can see more of the cavernous sinus. We peel a bit more, we clear it, we start to see the petroclival ligament. Here, this is the Gruber ligament, and this is the Dorello's canal. And then we start to see the carotid. So this is the petrous bone, so the horizontal part is hidden. Then we have the vertical part, and you can appreciate this is the clivus. The pituitary will be located here, and this is the carotid siphon related to the fourth and third, and also here is the fifth. So the sixth cranial nerve is always deep to the V1 and adjacent to the vertical part. So here is the appearance from here, which is exactly correlate when you see from below. So this is how we correlate it. So the paraclival carotid, which is the vertical petrous part here, is equivalent here. So we're looking through the sphenoid sinus, looking towards the left side. And then you can see the paracellar carotid, which is adjacent to this area. And you can appreciate that the V2, which is crosses the paraclival carotid, appears here on the lateral sphenoid wall, and is going to the pterygopalatine fossa. So here is this appearance, and then we come to here. This is the most informative slide of everything I'm going to show you, because we have opened the anteromedial and posterior lateral triangle, and we enter the sphenoid sinus. So the view we get from the sphenoid sinus, here it explains why the V2 appear in the lateral wall, and here what appears the paracellar and the clival carotid. But here we have the deep petrosal GSPN, greater petrosal nerve, to form the Vidian. And the Vidian nerve is emerging at the floor of the sphenoid sinus. So this is the most important view, again, magnified to correlate view from what we see from inside and outside. If you understand that, it makes it very easy to correlate your landmarks, and it's the difficult part we can see. Here we can see the rings, so this becomes the extra cavernous. So the cavernous segment of the carotid included the paracellar, this horizontal part, and most of the vertical part, not all of it. And here again, this is to put it all together and to correlate it with the angiogram. So if you look at an angiogram, you can know exactly which part of the carotid is related to which part of the cranial nerves and which part of the skull base. So that brings us to the floor of the sphenoid sinus. You know, the manubrious sternal angle is important in thoracic anatomy. There is a lot of landmarks, trachea, bifurcates, thoracic ducts, emerges, recurrent pharyngeal. So we use the floor of the sphenoid sinus. It's a concept inspired to us by Dr. Amin Qassam when he visited us for some courses in Cambridge. So what happens in the floor of the sphenoid sinus? At the floor of the sphenoid sinus, there is a lot of events. First, we have the Vidian canal, which I have showed you here. There is another small canal, the palatovaginal foramen or fissure, where it has the branches of the pharyngeal artery, but it is smaller, but not to mix it up with the Vidian canal, which is here. And if you go 45 degrees upwards and superiorly, you get the foramen rotundum. And you can see here the infraorbital nerves coming from the V2. So this is the floor of the sphenoid sinus, which is a very good landmark. And this is why. So this is the sphenoid bone, and here are the Vidian canals. 45 degrees, you can see the superior orbital fissure. This is the foramen rotundum. This is the pterygoid plate. And it correlates exactly with your landmark. So this is a very good landmark for this, but there is a lot of other events happening there. Of course, we have overlying it when you do surgery, articulation with the ethmoid air cells. And this important bone, the palatine bone that has a horizontal and a vertical part with an orbital plate and a pterygoid plate, this articulate with the sphenoid bone, and this becomes the sphenopalatine foramen, which sends up the sphenopalatine artery. But the problem that this where you get your nasal flap, and it's really lies the Vidian canal. So you have to go through that to get the Vidian nerve, which is a good landmark, as we can see. So this is the maxillary artery, the second part related to the pterygoid, lateral part in the pterygopalatine fossa, giving the descending palatine, and then it will enter here into the sphenopalatine artery and give again the posterior septal branch, which we use for the nasoseptal flap. So here is again another magnification to show you how the sphenopalatine artery is going to the medial meatus. So this is the nasal cavity. So again, this is to remind you, that's why in this appearance, this is where the Vidian canal is. It is at the floor, the lateral part of the floor of the sphenoid sinus. The other thing that happened that the vertical part of the carotid and the horizontal petrous, again, change direction at the floor of the sphenoid sinus. So what is the transition? If you see, this is the sphenoid bone, this is the lingua. So we have a petrolingual ligament, and this is really the ligament which divides the vertical from the horizontal part. In fact, this is called cavernous segment, but as I told you, the true anatomy, it starts above the V2 rather than from the beginning. Now, what happened to the C6, which is the horizontal part? So the carotid canal enters the petrous bone down here. This is your inner ear. And you can see here the vertical part related below the third part, the third division of the trigeminal. And this is important for middle fossa approaches. Here is your geniculate ganglion and the formation of the Vidian nerve. So if we drill the quasi-rhomboid here, which is the petrous apex medial to the horizontal carotid, it takes you down to the prepontine and the posterior fossa. The other important part related to the carotid is the cavernous compartments. And just simply, they are quite complicated. Now they are more important in endoscopic surgery for extension of functioning pituitary adenoma, which you want to clear. So there is lateral to the carotid, medial to the carotid, and superior part and inferior part, because the inferior part is around the paraclival carotid here, as you can see in these views. And this is an endoscopic view, lateral to the carotid, where you see the V1 and related to the sixth nerve, as I showed you previously in the cavernous sinus. So this is how we went through the carotid in the skull base. If you carry the carotid upwards to the supraclinoid, you have the two rings, the proximal and distal rings. So, and they are eccentric, so they are not really parallel. So they are open, concentrically open laterally, and we have this carotid cave related to the strut that has been removed here. And we have the ophthalmic artery going to the optic canal, and we have this is the superior hypophyseal branch. So this is the first part, the supraclinoid carotid, which you need to deroof the optic nerve to get a good view for it. So what this is important for, we do tuberculum and plenum meningiomas, and it's important to keep the blood supply, which is the superior hypophyseal artery. And really the two good views to get that is either the endoscopic view, but also the anterior interhemispheric will give you a good view. When you do the terional approach, your ipsilateral superior hypophyseal is away from you, and that's why you can have ischemia if you don't see, it's a blind spot. Paraclinoid aneurysm are important. We put them all together because when you are large, you don't know where they are arising for. But when they are small, you can have more or less these three divisions. Some comes from the superior hypophyseal origin, some comes from the ophthalmic origin, and rare ones come inside the carotid cave. You can either do a total clinoidectomy every time, or you can really tailor it. And all you need is just to remove the tip. In fact, the only ones that you may have to drill the strut is the carotid cave ones, which are very rare. But what is most important is the roofing of the optic canal. I cannot emphasize to you how it is important, because this is how you get position of the clip. Maybe less so for the last one, but it's very important. This is again to show you the superior hypophyseal branches are multiple. They give the stalk and also the chiasma, as you can see here. And this is why you need the space to put your clip. And this is another anatomical variations to show you the ophthalmic artery going below the optic nerve. So now this is the magnified view, and you can see this is all above the sphenoid sinus. Then the artery continues as ophthalmic artery into the orbit, and I won't cover the whole orbit, but you can see the two important arteries are the anterior and posterior ethmoidal artery. And this is starts behind the frontal sinus recess, and this is very near the optic nerve, as you can see here. One is obliquely and one is transverse. And just to remember the measurements, it is 24, 12, and 6 millimeters. So the transition, this is from the very front to the back. The transition here is behind the frontal sinus, while here it is between the plenum and cribriform plate. So this arteries leaves the orbit, goes the superior nasal cavity, and enters the cranium again. So if we look upwards through the endonasal route, we can see them. So this is the posterior ethmoidal artery. This is the anterior, just behind the frontal sinus, as you can see here. And they enter the cranium, and it is important because they give the falcine branch, which is can connect to deep veins, and this is the dural AV fistula, which you will find it adjacent to the crista galli. And all you need is just to disconnect the vein, and you get a good control like that. The other part in the orbit is the venous drainage. This is the superior ophthalmic coming through the superior orbital fissure, but it's connected to the cavernous sinus. So if you have a carotico cavernous fistula, you can see it dilated here. So this is just a glimpse of the anatomy of the orbit. And I have shown you that before. This is an AVM within the orbit around the ophthalmic artery. And it's not a dural fistula because it's draining here through the superior ophthalmic artery and not through the cranium. So this is an AVM of the orbit. So the last part of the talk related to transclival approaches, and we'll see what is the relationship. So the clivus have a superior third, the dorsum celli, where above the petrous apex, and the middle third, this is the jugular foramen, and a lower third with the hypoglossal nerve there. And the artery related to it, of course, is the basilar artery. And it's important for cases such as clival chordomas. And you can see here is the window, and we will see the relationship to the sphenoid sinus. So we study the anatomical landmark in Cambridge. It's mainly to know where is your corridor to the transclival approach. If you see a clival chordoma and it's around the vertebral artery, so you know which part of the clivus you need to look at. And we go back to the floor of the sphenoid sinus, and you can see here the floor of the sphenoid sinus have a relationship to the vertebrobasilar junction and also the pontomedullary junction. So we will try to study this again. So if you can see here in this view, this is the sixth nerve. So the sixth nerve, if you drill the clivus here, you can injure it. So you want to find where is the sixth nerve away from your lesion if there is a distortion by the lesion. It's come from the pontomedullary junction. So then it goes here into the Dorello's canal, as you can see here. So we did this study both in cadavers and radiological. We had a few cadavers which we have scans on the CT scan. And we find, despite the different variations, that the vertebrobasilar junction is really, really within a few millimeters of the floor of the sphenoid sinus. So this is, again, a very good landmark when you do clival chordomas. And we studied 100 subjects with MRI scan. We matched them on the sagittal views, and we measured the distance between the floor and the vertebrobasilar junction, and we correlated again with the pontomedullary junction. So the floor of the sphenoid sinus correlate with the vertebrobasilar junction. There is a little bit of variation due to the aeration of the sinus, but it is an accurate landmark. So in conclusion, the sphenoid sinus floor is another good landmark to the vertebrobasilar junction, which tells you where you are. If you have a scan that the chordoma is low, then you drill the clivus much below the sphenoid sinus. And also it will help you to identify where the sixth nerve if it is obscured by a chordoma. And just to demonstrate it in few seconds, this is a case of a clival chordoma. You can see it going to the medial cavernous sinus, and it has an intradural extension around the basilar artery. And again, we drill the clivus, as you can see here, is the bone is eroded more or less. And we can see now the paraclival carotid. This is the floor of the cella, this is the top below. And you can see the bone is already eroded, and with the chordoma emerging through the dura. There is a dural defect, which the chordomas are quite easy. As you can see, they are delivered easily because they are soft. And once we clear it, I promise you this is not more than another minute and a half of the video. And then we can look inside, we find the basilar artery. And on the sixth nerve, in this case, we did not have to find it at its origin because it was obvious here. Then we have to clear the chordoma from behind the upper part. And you can see this is the anterior inferior ICA, the ICA related to the sixth nerve, anterior inferior cerebellar artery. This is the basilar trunk. There is some adhesions with the chordoma with the basilar artery that is easy, can be dissected and teased off. And we'll see in a minute, because just to show you the whole idea is where this is here, the vertebrobasilar artery, and it's in flush with the floor of the sphenoid sinus, which is a good anatomical landmark. This is the top of the basilar, superior cerebellar, and this is a bifurcation in the two posterior cerebral artery. And then we look laterally, this is the sixth nerve, and there is an extension, as we see in the medial cavernous sinus. We have already drilled the paraclival carotid, so we know where it is. And you can see behind the sixth nerve. So we open the top first, we clear the top of the clivus, and then we return back and we get the rest. You can see easily because we have control of the carotid. And at the end, we resect the dura and we have the sixth nerve exposed. So thank you very much for I hope I got it in time, and thank you for listening to this talk.
Yeah, thank you. I think that you talked right on time. It's very informative talk, and it's very also informative in terms of correlating between the endoscopic anatomy and the open approaches, which is so clearly important to all of us, because the anatomy will be learned during our medical school and during a neurosurgical training. It's all different now. It's all endoscopic, and the anatomy is distorted and in a different perspective, but it's the same anatomy. So thank you for talking about this anatomy in particular. I don't have any other questions from the participants here, but unless anyone wants to ask any questions from the panelists, anyone? If not, thank you, Ramesh.
Thank you. Thank you.
Thanks very much. And we'll go on to the next speaker, who is Dr. Victor Perez from Mexico. He's a great friend, great anatomist, and a great neurosurgeon. So, Victor, it's all yours now.
Thank you very much. It's very nice to see you all and to present this work about posterior circulation. Here we have a picture with the basal aspect of the brain. Here we have the basilar artery, two vertebral arteries. One of them is hypoplastic, and here we have branches of these vertebral arteries. The posterior part of the circle of Willis is one of the most difficult sites to approach surgically. The complex series of perforating vessels surrounding and arising from it, and its intimate relationship with upper brain stem, extraocular nerves. The branches are exposed in surgical approach to the basilar apex, tentorial notch, lateral anterior ventricles, and inferior temporal. Here we have a small video. We can see the small branches coming from the tip of the basilar artery. Here we have the P1 and P1, the other side, posterior communicating artery. In this model, we can see the abscess of posterior communicating artery in the right side. Look at this segment of the posterior cerebral artery. We don't have connection with anterior circulation. Here we can see also the thalamo-perforating artery is the biggest of this group of arteries coming from the tip of basilar artery, and they overlap with some branches coming from P1 in both sides. Here we have another video in which we can see the posterior part of circle of Willis. In this side, we have an hypoplastic posterior communicating artery, and in this one, we can see these branches coming from posterior communicating artery and also from P1 and P2. So this video is very useful to know the critical anatomy in this part of the brain. As you know, these branches are very important because they are irrigating the stem, brain stem. This is the posterior perforated substance, and here we have this thalamo-perforating artery. These are small arachnoid tissue, and the advantage to inject these arteries is to differentiate these small branches of arachnoid with the arteries. Here we have two pictures in which we can see the posterior cerebral artery and anterior cerebellar artery. This is an approach to this part of the brain. This is a good landmark to differentiate the posterior cerebral artery and the superior cerebellar artery. Here we have some branches of P2, segment P2 with the posterior cerebral artery. These are temporal, anterior temporal, middle, and posterior temporal arteries coming from posterior cerebral artery. And here we have another beautiful branch that is coming most of the time from P2. This is the posterior choroidal artery. We divide in posterior choroidal, posteromedial and posterolateral choroidal arteries. You know that fetal configuration is the artery in which the proximal posterior cerebral artery, this one, is small, and the posterior communicating artery provides a major supply to the posterior cerebral artery and is larger than the P1. So this is P1. They are very short. Here we have another variation in the anatomy of these beautiful arteries. This is posterior communicating artery, and this one. They are both of them are fetal configuration, and this is a very long triad of P1 in the left side of this brain. Hypoplastic arterial segment is defined and one having a diameter of 1 millimeter or less, like in this view. This is a hypoplastic, is less than 1 millimeter of diameter. The posterior portion of the circle of Willis sends a series of perforating arteries into the diencephalon and midbrain. Some of the perforating branches arising from the upper part of the basilar artery overlap with some of those arising from the posterior circle. The risk of occlusion of these vital perforating vessels during tumor aneurysm surgery include visual loss, somesthetic disturbances, motor weakness, memory deficit, autonomic imbalance, diplopia, alteration of consciousness, abnormal movements, and endocrine disturbances. So this is very critical site of surgical procedures, especially aneurysm coming from the basilar artery. So here we have another video in which we can see absence of this posterior communicating artery, and P1 is giving some branches to the brain stem, to the posterior part of this anterior part of this brain stem. This is a posterior communicating artery coming from supraclavian carotid artery. This is P1. And is very known for all brain surgeons. So this is the main landmark in this approach to this region, the oculomotor nerve, and below of them is, below of it is the superior cerebellar artery, and above we have posterior cerebral artery. The oculomotor nerve in this site was accidentally cut during dissection. That's the reason we cannot see it here. So although you see a very small posterior communicating artery or PC or P1 segment of posterior cerebral artery, like in this case, you look that it's very, very small P1 in this site. But it doesn't matter if it is small or big. Look in the next picture, the numerous arteries coming from this very small P1 segment of posterior cerebral artery. Again, I'm going to put this picture in order to differentiate these arteries. Here we have the basilar tip of basilar artery, and this is the superior cerebellar artery in the right side, and this is P1. This is very small, and then in this we can see numerous branches coming from this spectacular P1 segment of a posterior cerebral artery. Segments of posterior cerebral artery, they are 4 segments. The P1 segment, also called the precommunicating segment, extends from the basilar bifurcation to the junction with the posterior communicating artery. A fetal configuration in which the P1 has a smaller diameter than the PCOM, and the posterior cerebral artery rises predominantly from the carotid artery, occurs in approximately 1/3 of hemispheres. The thalamo-perforating artery arises on the P1, like in this picture, and enter the brain by passing to the posterior perforated substance. Here we have another picture in which we can see these small branches coming from tip of basilar artery and P1. They are coming from these segments of the posterior circulation and gives irrigation to this important part of brain stem. This is a closer view in which we can see the trajectory of these small arteries coming from this segment of the posterior circulation of P1 and basilar tip. This is another view of basilar artery, posterior cerebral arteries, and superior cerebellar arteries. This basilar artery was cut in order to make some dissection of white fibers of pons. But we can see in this video another beautiful view of these arteries. Here we have P1, the right side, P2, and oculomotor nerves, and some branches coming from P1 and P2 of this. And here we have some arteries going to the oculomotor nerve and brain stem. The P2 segment begins at the posterior communicating artery, lies within the crural and ambient cisterns. This is the crural and ambient cisterns, and terminates lateral to the posterior edge of midbrain. The posterior choroidal arteries, the branches of posterior cerebral artery, enter the lateral anterior ventricles to supply the choroid plexus and ventricular walls, are divided into medial and lateral groups referred to as the medial posterior choroidal artery and lateral posterior choroidal arteries. So here we have a posterior cerebral artery. This is a special variation. I have not seen other brain like this, because in this there is absence of communication between anterior and posterior circulation. This is the superior cerebellar artery, and these are P1, but look at this. This artery is giving rise to some posterior choroidal arteries, and some of them are irrigating the peduncular brain, the peduncle of brain. Here we have a dissection of choroid of arachnoid in order to see these arteries. You know that dissection of this arachnoid is very important to preserve the fine irrigation of brain. So now we can see the crural and ambient cistern. This is fourth cranial nerve. And this artery is a superior cerebellar artery. Here we can see the oculomotor nerve, and just remember that this is a very important landmark. The artery above this oculomotor nerve is posterior cerebral artery, and the artery below is the superior cerebellar artery. The P3 or quadrigeminal segments proceed posteriorly from the posterior edge of the lateral surface of the midbrain and ambient cistern to reach the lateral part of the quadrigeminal cistern and ends at the anterior limit of the calcarine fissure. This is P4, this is cortical, these are cortical arteries, and this is P3 segment or quadrigeminal segment. In this picture, we can see the posteromedial choroidal artery and its irrigation to the pineal gland. This is pineal gland. This is a closer view in which we can see these important arteries. This is quadrigemin plaque, and this is pineal gland, and this is a small arachnoid that fix this pineal gland. This is a posteromedial choroidal artery, and this is most probably P4 segment. This is Rosenthal vein, and this is trochlear nerve in the right side. The P4 segment includes the branches distributed to the cortical surface. Like in this case, we have in here middle temporal artery, posterior temporal artery, and the calcarine artery. Hippocampal arteries, when they are present, arise in the crural or ambient cistern, and is the first cortical branch of the posterior cerebral artery. It supplies the oncus, anterior parahippocampal gyrus, and a hippocampal formation and the dentate gyrus. This is a dissection of white fibers in this brain. We can see in here this hippocampal artery coming from this posterior cerebral artery. This is really a nice dissection because when you find this artery, you look how this artery is giving rise, is irrigating the hippocampal formation, like in this picture. Here we have another view of this, And,
One more minute, Victor, one more minute.
A closer view of this segment of the peduncular of the peduncles of brain, the oculomotor nerve, posterior cerebral artery, and superior cerebellar artery. And these small arteries are also very, very interesting. They are irrigating the brain stem in the mesencephalon.
Victor, one more minute.
Here we have another view of posterior cerebral arteries and its branches, mainly temporal arteries. The dysfunction caused by occlusion of the individual posterior cerebral artery has been reviewed in the subsection related to those branches. This is a text copied from this beautiful writing of Dr. Roton. And the description of many affections of the brain is the involving of hypothalamic pathways, mammillary bodies, autonomic imbalance, damage of sympathetic and parasympathetic pathways in the anterior and posterior encephalon, alteration of consciousness, and many other more. This is a picture in brain stem, basilar artery, posterior cerebral artery, superior cerebral arteries, and this is a very beautiful region of brain.
Victor, it's time now. Victor, can you hear me?
Here we have a superior view of the basilar tip of these arteries. This is posterior cerebral artery, giving rise to numerous branches that are going to the brain stem.
Victor, can you hear me?
View.
Victor, can you hear me? Victor. I don't know whether Victor can hear me.
This is a very interesting variation of this basilar artery, tip of basilar artery. This is superior cerebral artery, P1, and P1 in the other side, but we don't have communication here with posterior communicating artery. Cerebellar arteries are defined in three neurovascular complexes: an upper complex related to the superior cerebellar artery, a middle complex related to the anterior-inferior cerebellar artery, and a lower complex related to a posterior cerebellar artery.
Victor, can you hear me?
Cerebellar arteries bear a consistent relationship to the superior, anterior-inferior, and posterior-inferior cerebellar arteries. Here we have superior cerebellar, anterior-inferior cerebellar, and some lower cranial nerves. This is irrigation of coming from the superior cerebellar artery. And here we have another interesting view of these arteries. And this is some dissections of these interesting arteries. I want to show you this beautiful view in which we can see the corticospinal. This is corticospinal. Look, the pyramid is located in here, and this is the causation. So I think that each brain should be dissected not only to study arteries and veins. Every brain should be dissected in order to understand the internal configuration, like in this case. Thank you very much.
Thanks very much, Victor. Can you hear me? There was some issue with your speakers. Can you hear me, Victor? Can you hear me? Victor, can you hear me? No, I don't think he can hear us. Maybe we'll ask him the questions whenever he can hear us. We'll check with him whether he can hear us. Then we'll ask the question that has been presented through the chat window. For now, I'm going to ask Professor Imad Kanan to say some few words about the speakers we have on the panel now, and also the eminent neurosurgeons to welcome.
While we are trying to get Dr. Victor to answer a question, I'd like to welcome three seniors. There have been a reflection of a great collaboration with the chair of the complication committee, Professor Keke Turel. He is on the podium. Can we see him on the panel? Pablo, can we put?
He's there.
Yeah, I'm not seeing him on my screen. Is he there somewhere?
I think Turel is there, but his video is not on.
No.
Okay.
My video is on. My audio is on. My video is on.
Yeah, but we are not seeing his youth image. And would like to welcome Professor Mahmoud Qureshi. He is the president of the Pan-African Society of Neurosurgery, has been instrumental in supporting education worldwide for young generation and in close collaboration with us. And Professor Atul Goel, a sincere friend, a brother, and a contributor to the advancement of skull-based surgery, and now with the craniocervical junction, he made a twist in the understanding. Welcome, three of you. I wish I could have put your picture so the young generation should see you, but they have seen you on different websites. But thank you very much.
Thank you. Thank you, Ima. Thanks for that. We will go on to the next speaker, and after that, I'll hand it over to Professor Kasadi after Professor Henry Schroeder's talk. And this is one talk, Henry, we're all looking forward to. You've got lots of interesting things to show us. So we're all looking forward to it. Thank you, Henry, for coming.
Yeah, thank you again to Imad and Vlad for the invitation to this nice webinar series. I think it is a very successful event, and I'm very happy to be part of it. And thank you also for the moderator, Ramesh.
Yeah.
And I hope I can hear you and you can stop me anytime. It is no problem for me. I can stop anytime. I just want to show some of these amazing variations. Victor has shown us so nicely the beautiful anatomy of the vessels in the posterior cranial fossa. And during hemifacial spasm surgery, you see so many variations. It's really amazing. No patient looks the same like the other one. It's really amazing. So that's why I had started my interest in and I just want to show you how we do the surgery shortly. So first, before we have an MR image, we have a patient it is a high resolution T2 weighted image. You see clearly the compression in the brainstem by a pica loop. And to differentiate between the vein and the artery, you have a pretty good idea about the real situation. And we did a study comparing the intra-operative evaluation inspection, and we found a very good correlation in the description when you have a simple compression of 96%, 91%. If we have a simple or a complex compression, the differentiation was also a 90%. So it gives a very good prediction in the MRI what you see really during the surgery, even if you have a complex case. So it's really recommended to have these two imaging modalities. And this is a series of our study. You see the most compressing and the combination pica with vertebral artery, ica with vertebral, pica, ica. Then sometimes there's a vein. What is very interesting, we had 2 cases where we saw or has not been described previously in the literature. I show you the cases later. So the surgical technique is an endoscope assisted. We put the patient supine. It's a small approach, easily done. We have a monitoring of facial nerve for the lateral spreads and also the acoustic evoked potentials to protect the hearing nerve. You see the lateral spreads typical for hemifacial spasm. And after decompression, you should have this line, and then you can be sure you have done a really good decompression. For the inspection, we use very small endoscopes, 2.7 millimeters, and we almost always use only the 45-degree endoscope because this enables a view down to the pontomedullary sulcus where the compression usually happens. This is our setup. We start always with a microscope. Some people ask, why don't you use the endoscope from the beginning? But in the beginning, there's no space. So the arachnoid dissection is much easier with a microscope. And then as the arachnoid falls down, after release of CSF, then you can use the endoscope very nicely. Most of the time, we have the endoscope freehand. And when we have a dissection, I like to fix it with the mechanical holding arm. And then I have both hands free for bimanual dissection, what we are used to have under the microscope. And this is really the advantage of the endoscope. You can inspect all areas of the subarachnoid space. You see really the course of the vessels, where they come from and where they end up. You see here the vertebral artery, abducens nerve, and then it comes like a common trunk, gives rise to ica and pica, and this is the facial nerve. So it gives you much better view to the anatomy. That's why it's strongly recommended that you have endoscope as an addition to the microscope. So when you start and you open the system, you see there's not much space. The endoscope is sometimes it interferes with your dissection. So that's why initially we start with a microscope, but then in the depths you see this is a facial nerve, and here's a compression of a loop, but you don't see exactly where it comes from. In the same patient now, we take a 45-degree endoscope, and you see the difference. You see the basilar artery, you see here a vessel coming, giving rise to ica and pica. So it's the common trunk, right from the basilar artery. You see the facial nerve, and you see here clearly the compression. This is a close view. Shows you here's the compression of the facial nerve, but also down in the sulcus, the facial nerve as well. And then usually we take it with a microscope again. We bring some Teflon in, decompress it, and then we shake it again. The endoscope to make sure that we have a good decompression, no contact between the artery and the nerve. So when we start from the beginning, this is microsurgical dissection view of the nerve. The first nerve is the glossopharyngeal nerve, then you have the vagus nerve, and these are very important branches, very thin, but very important. These are the cranial branches of the accessory nerve containing the fibers for the larynx. So if you dissect too much and manipulate too much, the patient may wake up with hoarseness. We had some cases, but usually it resolved after a few months, and this is spinal accessory nerve. And then you see here the hypoglossal nerve. The hypoglossal nerve is a good indication where's the origin of the pica from the vertebral artery. And sometimes if you have this elongation of the vertebral, the hypoglossal nerve is very long, very elongated by this extension or by the elongation of the vertebral artery. So the origin from the pica, which usually is down, comes up. And then you see the hypoglossal nerve is elongated, but still going around the origin. So if you see the hypoglossal nerve, you know this is the pica here. And with the endoscope, again, you see the much better view. You see abducens nerve here. So you see here, the vertebral artery, this is the origin of the pica. Hypoglossal nerve is turning around the pica, and this is the ica loop coming from the basilar. But first, we put the endoscope into the CSF to avoid fogging of the lens, and you see here vertebral artery, and here's the pica loop, and you see here clearly the compression, and you see here the vestibular cochlear nerve, and the facial nerve. It's interesting, we saw a lot of compressions of the vestibulocochlear nerve in our series, but no patient has this vestibular paroxysmia, not a single patient. Although there was clearly also a severe compression of vestibulocochlear nerve. So this is the ICA. The ICA is originating from the basilar artery, makes a loop and compressing here the facial nerve. After decompression, you see here is a second branch giving rise to the labyrinth artery in the internal auditory canal, and this has to be decompressed as well. Be careful that there's no after the transposition. Again, an example of the ICA common trunk. This is a pica. And sometimes ICA is running in between 7 and 8. You see a 7 nerve, 8 nerve, and this is the surface. It comes here. Then it goes in between the nerves. These are the cases which are difficult to decompress because you cannot transpose as far away. So you have just to put some metal in between. Make an suture. But I think this is not a very well accepted treatment modality. We had one case, there was a small vessel running through the nerve. We decompressed it here. The patient was completely free of spasms without touching the small vessel within the nerve. Sometimes you have a sandwich compression that means compressing the facial nerve, but this very peripheral contact. In all of our series, we always have a proximal contact. This is a contact to hemifacial spasm. In our series, usually we see a compression at the proximal area where the nerve comes from the brainstem. So this is ICA right here. If you're down, you see it's coming. If you're looking closer, there's a vein. So the ICA loop up here has nothing to do with the symptoms. The problem is here, the vein and the compression between vein and ICA. And then you see the grooving in the nerve indicating the structural damage to the facial nerve. But this ICA has nothing to do with no problems. We do not touch it. The patient complaints resolved. This is ICA and pica sandwich compression, can always be. You see the ICA running here, ICA coming from low, and the nerve is in between compressor sandwich compression between ICA loop and pica. Sometimes we have all three vessels involved. Here, artery, and see the pica, so you might think that pica is a problem. You see here, this is the hypoglossal nerve, vertebral artery. So there's one loop, but you don't see another vessel. So this is the origin of the pica indicated by the hypoglossal nerve. It makes this loop going up here, going down, and then it comes back to the surface of the cerebellum. But there's another vessel down. This is the ICA loop. After decompression, you see it. This is the pica running here, going there, coming up, but there is a third vessel. So it's a very complex compression with vertebral artery, ICA, and pica.
Henry, there's something. Yes? There seems to be some problem with your audio. It's sort of waxing and waning, and at times it's good, and at times it's not very clear. So some of the audience is not here listening or hearing it properly.
Oh, that's bad. But we usually have a good contact here.
Yeah,
it's now good.
Yeah, well, it's good at times, but now it's good. But sometimes when you talk, it just goes off.
All right. So, but I think I cannot change it now.
Sure. Yeah, I know it's a bit late, but it's okay. At least it's good. You can see your pictures.
Okay. The more important, the pictures. So here's another compression. The common trunk gives rise to ICA, pica, and here you see the facial nerve. After decompression, ICA loop, pica loop. The compression is always different. This is vertebral artery and ICA, double compression. You see the vertebral artery running here. And there's a second artery running there, also with contact. So the vertebral artery, here you see the second artery, both have contact with the facial nerve. See the grooving here? That is a double compression. Vertebral artery alone can also be compressed. You see the vertebral artery making this loop. Severe grooving of the facial nerve. And if you elevate it, you see severe structural damage. Can you hear me or not? Ramesh?
Henry?
Yeah?
Yeah, we can hear you, but it's become a bit unstable at times. So there is one suggestion that you could turn off your video. You know, if you stop video and just carry on with your presentation and showing the screen, it might work better in terms of the internet connection. If you just turn off your video. Okay, let's try that.
All right.
It's better already.
Good. You see, this is a vertebral artery compression. Facial nerve, and if you have this severe compression, it's not enough to place something in between, but it's better to make a loop around. And then you fix it with advantage compared to the features that you can retighten it if you see it's not enough tension. And then you look down, there's no contact between the facial nerve. Ramesh?
Sorry, Henry, I think it's still same issue. We still have some issues with your audio. Not sure what's happening, but we can, at times it's good. We can't hear you. We can't hear anything now.
Now? Okay.
Yeah, now, yeah.
Okay. ICA and vertebral artery compression together, vertebral artery facial nerve. You see here double compression. After decompression, you see this is a grooving in the facial nerve. Sometimes you have a tandem compression. That means one vessel is pushed by the other against the facial nerve. So vertebral artery is pushing the pica against the facial, and you see here the grooving in the facial nerve. So it's very variable with the compression pattern. Again, vertebral artery here and pica here. Vertebral artery and pica. Double compression, both are in contact. Pica and vertebral, facial nerve, vestibulocochlear nerve. This is the ICA loop, which is not contributing to the compression in this patient. And after decompression. And sometimes you have a compression which goes far up into the brainstem. You see it's in the pontine area, visible. And in these cases, I could not, we have 3 of these patients, I could not see the compression side. It's so far here, with the microscope, it was impossible to see. So we had to use the 45-degree endoscope. Looking down, see this complementary size you see here is a loop. Because it was not accessible with a microscope, we fixed the endoscope with a mechanical holding arm. And the loop is mobilized under visualization to avoid too much retraction. So it's very helpful with 45 endoscopy. Sometimes you have an artery and the vein in between the brainstem surface and the facial nerve. This is the intermedius nerve. You see the pica loop and the vein running in between the surface of the brainstem and the facial nerve, compressing it from both sides. Sandwich compression. And here again, the big vein running on the brainstem. Here was the compression by pica. And the view shows the vein, facial nerve. We had one strange compression pattern. See, this is like venous extension. Venous looks. This is the ICA, this is the facial nerve. So we decompressed it here. Put the Teflon here, and then we coagulated this. This is a genetic problem, but you see good decompression, and the spasm disappeared immediately after surgery. Only the compressing vessel. You see here the big vein, the facial nerve, and the branch going around the facial nerve, so making the squeezing of the nerve in this area. You see here the damage in the facial nerve, and then we put a Teflon sling and fix it with a suture to the dura at the skull base to keep this area completely free. Any facial spasm, and see MRI shows no compression at all. The TOF shows no vessel, and if you see here severe strangulation of the nerve by arachnoid. On the medial side, no compression, just ICA running here, but it's not causing compression. We just cut this arachnoid patient. Another patient, since his age of 12 years, so for 20 years, he had this problem. He was 32 and he came to us, and you see this is the healthy side, and on the left side, the spasm there was. The facial nerve is originating more anteriorly from the brainstem, but again, no vessel visible, no compression. Look at the severe strangulation. It's amazing. And here's a neural tissue pulling the nerve anteriorly. That's why maybe it's so far anteriorly positioned. So that's also a developmental problem. And you see after cutting of this arachnoid, a severe thinning of the nerve. It was amazing. Immediately after surgery, so there was no compression. Very interesting. And one case with severe arachnoid fibrosis. And the last case I want to show is an arachnoid compression. This arachnoid testing the ICA to 7th and 8th nerve. And we just cut it and put some Teflon, and the patient improved. The conclusion is that it's really amazing variable in the posterior cranial fossa, and each patient looks different. And I can strongly recommend that you use an endoscope with 45-degree endoscope to look down to see the microscope. And I have seen a lot of patients which had surgery only with a microscope. The ICA was decompressed and the pica down in the sulcus was overlooked because no endoscope was used. Thank you for your attention. Sorry for the problems with the voice.
Ramesh?
Yeah, Henry.
May I interfere 1 second only?
Sure. Yeah,
I just want to reassure all the registrant and attendants that this problem with the voice and with the microphone, for the nice presentation of Henry, we are going to hopefully reschedule it with the approval of Henry, because unfortunately the voice was not very clear and we all missed part of the value of it. The picture were fantastic, but we could not hear you. So if it's agreeable to Henry, we are going to put it in one of the future sessions, just for all the registrants to be aware of. Thank you.
Yeah, I totally agree. I think it was a great presentation as always, but the audio quality wasn't great. And maybe we can, me and Pablo and some of us can sit together and try and find out what the issue with the audio setting is, Henry.
Yeah, sorry for that.
No,
we tested it and everything went well. So I don't know what it is.
No, we can hear you now very well. Now, maybe it's, I don't know, something's wrong with the computer noise and your noise, maybe not. It's a matter of checking the audio settings. We'll do that after this.
Okay.
All right. There are a few questions, though. If you don't mind, there are a few questions, if you don't mind answering, Henry. Got 1 or 2 minutes for questions. So one question was about the heat injury from the endoscope tape. Is that something that you would be concerned about?
Of course, you have to be very careful. That's why we always have a lot of irrigation. But in a hemifacial spasm surgery, we put the endoscope only shortly for inspection. So we move it in and out. And we always have the tip in the water to avoid fogging, so it's not dry. And then we irrigate. If you have tumor surgery and we fix it, then we have also a lot of irrigation. If you are very close with the endoscope and keep it there for a long time without irrigation, of course, this may cause damage to the nerves. Yeah.
All right. Yeah. Thank you. And the other question was about what is the incidence of facial palsy after decompression? How do you manage it? From Seema Sharafat.
Yeah. So we have a 7% rate of facial palsy in our series. But most of them, 3/4 of them, are not caused by dissection, but are delayed facial palsies, which we see also in tumor surgery. Usually they start exactly on day 10. And nobody knows exactly what it is. Usually people consider it is a viral problem. But we have half of the patient which received virostatic agents, acyclovir, and half of them did nothing. And in all patients, it resolved. Because of direct manipulations, we had some when the vertebral artery was very elongated and calcified, so arteriosclerotic vessels in older patients. There we had also a palsy from the dissection, but in all patients it resolved at least to grade 2 or 3.
Thank you. There's 2 more questions, and after that we'll go on to the next session. One question was, I think it's a very common question that comes up whenever we talk about the MVD. What do you do when you don't see any compression?
Now, what I have shown, then I look for anything else. And hemifacial spasm, if the diagnosis is correct, you see something. Usually it's a vessel. But we have these 2 cases, which is arachnoid strangulation, which were very interesting. And we just opened this strangulation. We just cut the arachnoid, and the spasms disappeared completely. And I just called the 2 patients. It's now 1.5, and the other is already 2.5 years after surgery, and they are both doing fine. And if you have, if you don't see anything, you must be careful with the differential diagnosis. So facial tic can be a differential diagnosis. Dystonia can be a differential diagnosis. And we had one patient who had the facial palsy but did not told us, and he has synkinesias, like we see after trauma. So it was not a hemifacial spasm, although it looks so when you look at him and he was talking.
Thank you. Thanks, Henry. There's one more. Do any of these patients have any 8th nerve problems?
Yes, of course. We have a 3% rate of hearing loss. Usually in older patients who presented already with presbyacusis. So they had already decreased hearing. And in 3%, we had a loss of hearing. Some patients have a little bit of decreased hearing, maybe because water goes into the mastoid, but this usually resolves. But we have the 3% rate of anacusis in this series.
Thank you. Thanks very much. I mean, I now understand what your problem is with the audio. I think when you screen share, maybe the audio from your videos or the screen is interfering with your own audio. I think that's the issue. That's something which can be easily rectified for the next talk.
May I ask you one last question to Henry?
Yes.
When you have a recurrence, how long you wait to do the second surgery?
It depends. Really, it depends. Usually I wait at least a year. We had one patient who was completely free of spasm after 2 years. It was amazing, really. But he has a tendency to improvement. It was better, then it became worse. But there was a continuing improvement. If you have a patient, he is free of spasm. After 3 months, he starts again and becomes worse, worse, and worse. I would not wait 1 year. I usually go in. So it's very individual decision, but it is very clear that many patients need a longer time. There's a recommendation from a Chinese group. They say if the spasm is not away after surgery, they recommend an immediate revision. But this, I think, it's not correct because we have a lot of patients where I put a loop, the vessel was far away from the nerve, so it cannot be improved, but they still had the vasospasm because the nerve needs some time after lifelong compression. Do you agree?
Thank you. Yes, I agree completely.
Yeah.
Thanks, Henry. And that's a wonderful session. And I'm just going to ask my great friend, Professor Kasadi Kalunku, to introduce our next speaker. Thank you. And Henry, before I go, just there are a few questions on the question and answer chat window. If you get time, just try and do specific questions to you, if you don't mind answering them on the chat.
All right.
Thank you. All right, Kasadi, are you there? Kasadi, are you? Yeah, can you unmute?
Yes, here we are. Can you hear me?
Yes.
Okay, good. Thank you very much for your introduction, and congratulations to other colleagues who have presented. It was very fantastic, very well. So I'm going to introduce Professor Mattias Baldoncini, who is going to talk to us about optic foraminotomy as an alternative for ophthalmic aneurysm. Please go ahead, Professor Mattias Baldoncini.
Professor Casadi, can you hear me okay?
Yes, we can hear you.
Okay, thanks, Ramesh. First of all, thank you very much to the committee for this kind invitation, and special thanks to Professor Imad and Vladimir, our chairman and co-chairman of the committee. Okay, I will try to explain why the optic foraminotomy could be a good alternative for clipping some special small superior ophthalmic aneurysms. And first of all, I want to remember an interesting phrase, especially for young neurosurgeons around the world, that is, you need to see the anatomy before the anatomy see you. And the only way to accomplish this goal is going to the skull-based laboratory. And this is very important to training in the laboratory and not with patients. This is an interesting suggestion that I received some years ago, and I try to do every time. Okay, for skull-based surgery, you need to keep in mind the skull-based anatomy. You need to do excellent preoperative studies like tomography, resonance, and angiographies, and of course the microsurgical skills that you can accomplish good microsurgical skill into the laboratory training with cadavers first to go to the patients. Okay, these interesting regions of the anterior and medial skull base is very important because the neurosurgeons need to work here for clipping aneurysms of the carotid segment or for removing some kind of meningiomas like tuberculum meningioma cellae or like clinoidal meningioma. And this is very important to the management of this region, because sometimes for a good removal of the tumor or for clipping some kind of aneurysms, you need to drill to remove some bony structures to accomplish these objectives. For clipping this kind of aneurysm, most neurosurgeons try to remove the anterior clinoid process through extradural clinoidectomy or intradural clinoidectomy. We think that this procedure we need to do when it's really necessary, but in some kind of aneurysms, you only can accomplish this objective only removing the roof of the optic canal and a little bit of the medial and lateral wall of the optic canal, okay? This is why we try to use the term optic foraminotomy instead to optic unroofing, because we try to remove a little bit of the medial and lateral wall of the optic canal, okay? For performing the anterior clinoidectomy, you know that you need to do a peeling of the middle cranial, a small peeling of the middle cranial fossa. You need to achieve the orbitomeningeal band. You need to cut the orbitomeningeal band, and then you need to cut the with the drill the superior surface of the clinoid. You need to drill the medial limit of the optic canal, and then you need to drill the optic strut. This process sometimes is very difficult, especially for young neurosurgeons, and not every time is just necessary. Okay, we can see here the optic strut of the clinoid process, and here the medial extension of the anterior clinoid process that covers the optic nerve. We try to perform only the remotion of this bony structure for clipping these small aneurysms. Here, I share in my screen two works that we have published. Here, the importance of the orbitomeningeal band for clipping some kind of aneurysm or for removal some kind of meningiomas, and for performing anterior clinoidectomy. This work is published in the Operative Neurosurgery, and this video in our National Argentinian Neurosurgery Journal, Optical Foraminotomy for clipping carotid ophthalmic aneurysm. I am sharing here a small aneurysm arising from the ophthalmic segment of the carotid artery. Professor Rames Quirolo gave us a beautiful lecture about this anatomic segment of the carotid artery. And it is very important when you need to perform a drilling of the optic canal to study the CT in the bone windows, because sometimes in the superior surface of the optic canal, you cannot have bony structures, and you can have only dural dura mater from the anterior cranial fossa. These original drawings were made especially for explain this kind of aneurysms and the close relation with the origin of the ophthalmic artery. Superior view, we can observe the ophthalmic segment of the carotid artery. That is a short segment that start from the origin of the ophthalmic artery to the origin of the posterior communicating artery. Okay, here in this beautiful dissection of the anterior and middle skull base, we can observe the optic nerve dissected and the anterior clinoidectomy performed in order to see this fixed segment of the carotid artery, the clinoid segment, and this segment is fixed in their place with these proximal and distal dural rings. Here, another view of the anterior cranial and middle cranial fossa. You can observe this structure that is very important to keep in mind when you need to work over the optic nerve. That is the ligament, the falciform ligament. Here is present. Because we need to remove first the dura mater covering this structure, and we use the free edge of the falciform ligament in order to cut this membrane anteriorly. Here we can observe that the optic nerve have a special dural sheath externally.
Sorry to interrupt 1 second. There is a microphone which should be probably muted because it is interfering with the lecture. Thank you very much.
Go to Henry. Yeah, Kadri. I think it was Henry. That's fine now.
It's okay?
It's okay now.
Please go ahead. It's okay.
Okay, thank you. It's very important to keep in mind that in the process of removing the bony structures over the optic canal, you have a special protection of the vessels of the optic nerve in this intracanalicular segment, that is the dural sheath and external protection. It's very important to keep in mind the close relation with the anterior clinoid process and the optic canal with the sphenoid sinus. Professor Rams-Kirolo gave us a beautiful lecture and beautiful pictures that we can observe the close relation between this sphenoid cavity inside of the bony of the sphenoid bone, because in the process of performing a clinoidectomy or optic foraminotomy, we can produce a small hole inside of the sphenoid sinus, and this is a real problem because we can produce cerebral spinal fluid rhinorrhea. We can observe here the optic carotid recess and the optic protuberance. That is very important because this is the bony structure that sometimes you need to drill in the medial side of the optic nerve. Of course, the vascularization of the dura mater is very, very important because sometimes we have to operate not only aneurysm in this region, and you need to keep in mind the vascularization of this zone. I strongly recommend this article from Carolina Martins. Can you hear me okay?
Yes, we can hear you. Yes, fine.
Thanks. And the dural arteries involved in these regions are especially the capsular arteries, the posterior sphenoidal arteries, and the recurrent meningeal artery that emerge from the orbit to the through the lateral side of the orbital fissure to the medial fossa, medial cranial fossa. Now I want to show you an interesting video about the optic foraminotomy that we made in 2 patients for clipping superior small carotid ophthalmic aneurysms.
Okay. Yeah. This specially drawn
This,
original
sorry.
segment of the internal carotid.
Sorry. These special drawings, as I said before, were made especially for describe these small aneurysms that can be clipped, at least for our team, without the need for removal of the clinoid process and only performing an optic foraminotomy. Here we have the optic nerve, the carotid artery, and as I said to you before, the optic nerve have a small extension of the arachnoid inside of the intracanalicular segment that is covered externally by the optic sheath. The optic sheath is an extension of a dura structure that covers completely the intracanalicular segment of the optic canal. It is very important. We start to perform the optic foraminotomy from the base of the anterior clinoid fossa. We need to coagulate sometimes, and medially we made the incision, the dural incisions, laterally to the tuberculum sella and anteriorly to the free edge of the ligament, falciform ligament. This is very important because it's a constant structure that we have present in the skull base. We present here a case of a male patient, 54 years old, with history of ischemic transient attacks some years ago and visual field loss. And in the diagnosis with angiogram and angio-CT, we can observe the left superior carotid aneurysms. Here in the picture on our left, the superior view of these small ophthalmic aneurysms, and in the right we can observe highlighted here the lateral view of this small aneurysm. We operate the patient in a common supine position, we perform a pterional approach with interfacial dissection of the facial nerve as regularly for this kind of aneurysm, and with the 15 rotation to the contralateral side. We perform a Transilvian approach. The audio is okay, Ramesh?
Video is fine, Matthias. Thank you.
Okay, okay. We perform a Transilvian approach, and firstly, to cut the dura mater, we prefer to coagulate it with a low bipolar coagulation of our curvilinear incision that I showed you before in this anatomical specimen. This avoids some small bleeding from the dural arteries of that region. We prefer to cut the dura mater and remove it before the drilling. 10 millimeters anteriorly to the anterior border of the falciform ligament is the distance that we perform the drilling. With the 11 blade, we cut the falciform ligament and start the drilling process with a small tip drill. It is a 3 millimeters diamond tip drilling. We prefer to do it slowly and with a high irrigation. And as you can see in this video, we try to drill not only the roof of the optic nerve, instead we try to drill the medial surface and the lateral surface. In other words, the medial surface of the anterior clinoid process. And we have to be very careful in the drilling process in this region, in the medial side of the optic canal, because we have here, as I told you some minutes ago, we have here the sphenoid sinus. After that, we can cut the optic sheet in order to mobilize the optic nerve and the carotid artery for creating the space for clipping this small aneurysm. We can see here that the optic nerve have a small protrusion in some millimeters posteriorly to the border of the falciform ligament. And we can observe with small microdissection, small pain-filled microdissection, dissecting the arachnoid between the space of the carotid, optic carotid space, and we can observe this small aneurysm and the point where the ophthalmic artery is leaving the carotid artery for introducing in the inferior surface of the nerve. Here we clipped these aneurysms with a straight 5 millimeters clip without the need of removal of the clinoid process to perform this surgery. Only removing the roof, the medial and lateral wall of the optic nerve. We can observe here the point where the ophthalmic artery is leaving the carotid artery there. Again, only 10 millimeters, we drill the roof of the optic canal. It is very important to expose the free edge of the falciform ligament in order to have a constant structure of the skull base to perform our optic unroofing and drilling the medial and lateral surface of the optic canal. Again, in other words, we try to say optic foraminotomy because we
luego le da envidia al cabrón y empieza a chingar.
Here highlighted the postoperative angiosity of
también.
patient, the patient 1 month postoperatively.
Igual me lo llevo, sí. Las llaves.
Here
Sorry
another
for
case.
sorry for interruption again. There is a microphone which should be maybe muted.
I think it's from the video, Natalie.
No están las llaves
Sorry?
de Chevy.
I think it's
Can
from
you
the
hear me?
video.
Aquí están.
Oh.
Ya me voy.
Can you hear me okay?
Yeah, we can hear you, but
Good.
some
Go
noise
ahead.
in the background.
We can hear. Thank you.
Another case, a female, 43 years old, history of subarachnoid hemorrhage, and in the angio-CT and angiography, we can observe a carotid ophthalmic aneurysm and M1 aneurysm 2 in this patient. This kind of aneurysm frequently associated with another kind of aneurysm, not only superior ophthalmic aneurysm.
No.
The same, we expose the patient with a pterional approach and the cervical carotid artery plus a pterional craniotomy, and the same transsylvian approach, and we can observe here exactly the same. The optic nerve with a curvilinear shape over the superior surface due to the aneurysm located in the inferior surface. We cut the free edge of the falciform ligament and we remove the bony structures in the roof of the optic nerve, the medial wall of the optic canal, and the lateral wall too. And with this simple technique, simple and quick technique, we can expose the neck of the aneurysm that was clipped with a 7 millimeters angle definitive clip in this female patient. The postoperative showing the two aneurysms clipped, and of course the patient in the postoperative with a good result and improving their visual deficit comparing with the preoperative studies. Thank you very much.
Thank you very much. Thank you very much, Matthias Baldontieri, for this excellent presentation, the lecture. I can see one question here from Norhunda Maria. She's asking, what is your attitude when you find a non-ruptured, unruptured ophthalmic artery aneurysm?
Well, in my hospital, we have a strong service of microsurgery, but in young patients, we try to operate the patient. In small and no ruptured aneurysms, we try to operate. In adult patients, we can send the patient to the endovascular service.
Okay.
You know this.
Thank you very much. There is another question here. Do you have a worsening of visual deficit because of the mobilization of the optic nerve to join its posterior part?
Yes. We have not worsening of visual deficit. Instead, we have improvement of the visual deficit in our patients. We have not a lot of cases operated through optic foraminotomy. We have 7 patients that we use this technique, and the patient, any one of that patient worsened the visual deficit.
Okay.
We try to mobilize the carotid artery firstly, yes, and try to avoid to mobilize the optic nerve in order to avoid the damage of the PL vessels of the proper vessel of the optic nerve.
Okay, okay. Still on the same line, there is Raul Kumar is asking, is there any increase in vision loss
No.
No.
I want to share our experience with this technique. With the approval of Professor Michael Lawton, we tried to publicate this technique, but it was rejected from 4 journals of neurosurgery because all the revisors said you can't operate and mobilize the nerve in this way and have not worsening of the visual function. And we sent the visual studies in the preoperative and the postoperative, but what, you know, it's controversial.
Okay. One more question from Gino Mendoza Vega. If you have an intraoperative rupture, where is the proximal control?
As I show you in the second case, in all that patients, we expose firstly the cervical carotid artery in order to have the proximal control in this segment of the carotid. Okay,
perfect. Thank you so much, and congratulations again.
Thank you, and thanks again to Ramesh, Vladimir, and Alman.
Thanks very much. Okay.
Matthias, there's a small comment from my side. Matthias.
Hi,
hello. Yeah, Matthias, good presentation, excellent presentation. You know, when you are, I mean, also depends on your trajectory to this aneurysm. If, I mean, I see that you are cutting the optic, I mean, you are unroofing the optic foramen only and clipping these aneurysms. But I would think that for a young neurosurgeon, it would be even difficult than a clinoidectomy. I would rather advise a clinoidectomy, and along with the clinoidectomy to unroof the optic nerve, because if you don't really know the trajectory of the aneurysm, what I have noticed is you're going underneath the optic nerve and you're clipping these, and you seem to be very, very sure about the trajectory of this aneurysm. And if there is a young neurosurgeon who's not very clear about the trajectory of this aneurysm, and if he does just optic roof unroofing and try to go in from a lateral trajectory under the optic nerve, it's going to be a lot of stretch to the optic nerve, and plus there's a chance of, you know, a rupture. And if you have a rupture in this region without clinoidectomy, this can be a disaster. So I think somebody should reach your level of, you know, you reach your expertise and also study very clearly as to what is the trajectory from where you can clip the aneurysm, and then only go ahead and do this. But having said that, if you can avoid all the other things and just go ahead and do this, it's a beautiful, you know, it's a fantastic procedure.
Thank you very much, my friend.
Thank you very much. Thank you very much. Matthias, if you can maybe look at the Q&A and answer the questions maybe directly to the people who are asked. There are some more questions to be answered.
Of course, my pleasure.
Okay, that's good. Okay, let me introduce Professor Vladimir Benes, Vladimir, who is going to talk to us about MCA aneurysms, how I do it. Please, Vladimir.
Yeah, thank you, Kazadi.
How are you?
How are you? I'm fine. How are you?
I'm fine. Always young, huh?
Good. I just remember meeting you in Prague and overlooking you in the dark. Do you remember that? Okay. Hello, everyone. It's my pleasure to follow Matthias with his excellent lecture on ophthalmic aneurysms. And I fully agree with you that it's not necessary to resect the anterior clinoid in all cases. It's you just target your drilling. But let me go a little to the periphery and talk about the MCA aneurysms. A while ago, we have published 2 articles on aneurysms. One of them was on anterior communicating, and it was coil mainly. And the other one was on middle cerebral aneurysms, and it was clipped first. I shall get to both these articles at the end just to show you the results and why we said coil first and clip first. So how we do it, the middle cerebral. Lumbar drain is the best invention in neurosurgery, which I have said many times, and my residents cannot start the craniotomy unless the drainage works. Then a regular pterional craniotomy, and the arachnoid is opened only in the length of 20-25 millimeters of Sylvian fissure on the convexity, exactly at the curve where the base of the brain turns into the convexity. Nothing more is needed. Then the dissection proceeds first to the distal M1 segment to secure the parent artery, going back to the aneurysm, clip the aneurysm, coagulate the aneurysm. We quite frequently resect the sac for further flow studies. Then, of course, check with ICG, and in certain cases, we perform intra-op MR to see the diffusion-weighted images to rule out any ischemia, but that's not routine. So this is the craniotomy and the exposed Sylvian fissure. This is not about the minimal invasivity, about the keyhole surgery or something like that. The craniotomy must be regular size, and the minimal invasivity comes only after this. I always consider minimal invasivity if you are minimally invasive in relation to the brain and its vasculature, not to the skin and bone and all the other unimportant structures. So the minimal invasivity is this in my mind, 20 millimeters cut of the Sylvian fissure, going directly to the aneurysm, which is seen here, clipping the aneurysm, coagulating the aneurysm, what Juha, Ernest's name, is calling kill the aneurysm. And this is it. This is 20 millimeters cut in the arachnoid in the whole length. So let's see it on the video. This is the middle cerebral aneurysm. And here's the video. You see that we go directly to the aneurysm. At this point, I already have the distal M1 secured to put the temporary clip whenever necessary. I do not really try to dissect everything out of the aneurysm, all the vessels going on the sac. What's important is to find the neck. And my favorite instrument in these surgeries, of course, is scissors, because they are sharp and you do not tear anything. And as long as you do not tear anything, you do not produce any hole in the aneurysm sac. You see the distal M1 on the image, which is over here. Now it's temporary clip being put on. Here's the sac of the aneurysm. This passing artery, I've never dissected free from the aneurysm at this point because it's not necessary, since I see both M2 segments. I see the M1 segment, I see the middle cerebral tip. You see that just throwing the clip into the area doesn't help. You need really to adjust the clip properly. And it's like that. This is the aneurysm for 1 or 2 clips at most. So you have room enough, you have enough of the overside of the surgical field, and you can very nicely control the clip adjustments and aneurysm closure. That's it. Now the temporary clip is removed, and the whole aneurysm will be now killed. First, this vessel is dissected free. Now you can hardly produce any rupture, and this is the aneurysm sac, which is coagulated. We then cut it away for the further studies. You will see the whole MCA division, and you check the flow with the ICG, which will be done now. You see that you can even work with the ICG. This is the aneurysmal sac, which I move now, and all the vessels which are of importance in the area. So this is it, and this is easy. This is post-op angio. We now have a rule to have all the aneurysms after the clipping checked by the angio, especially 3D angio, which definitely is the best means to check your work. What's quite frequent in middle cerebral artery aneurysms, which is like here, this is enlarged. This is not the direct image. This is already enlarged image from the microscope. You see these tiny blebs on the middle cerebral artery, which are beyond your possibility of clipping with regular clip. So I do not hesitate to wrap it with a piece of cottonoid, because these are the pre-aneurysmal formations which may produce new aneurysm in few years in future. With this approach, small, simple approach following any artery down to MCA division, you can even play with your aneurysm. You can check everything. You have enough oversight, and you can use multiple clips, which is quite frequently needed in middle cerebral artery aneurysms, since these are sometimes difficult and sometimes many various clips should be used, and multiple clips, like in this aneurysm, which encompasses again the tip of the MCA division. Here is frontal, here is temporal, here is the aneurysm, and first clip will be put directly along the axis of the M1 on the frontal side to exclude the part of the aneurysm which is looking frontally. This is it. And now we are left with the part of the aneurysm which is on the top of M1 and looking to the temporal side. So another clip is occluding the direct part of the sac. The third clip now will be put on the temporal side, just to preserve the division perfectly free. And then the fourth clip is put in between the former two. So actually there are 4 clips on this aneurysm, and still being applied with this, say, minimally invasive approach to the middle cerebral artery. You need nothing else. You do not need to see the carotid. You do not need to see the optic nerve, nothing like that. It's fast, easy, and very straightforward. Actually, exactly the same technique we are using for large aneurysms. Of course, here the Sylvian opening a little wider, but never going to the skull base. You see the distal M1 with its perforators, which is now being clipped. Then this M2, which actually later on we disclosed was already M3 segment, is temporarily occluded. And lastly, the other M2 segment, which is hidden over here, is occluded. To be quite honest, at this point, we already have STA, MCA bypass on the temporal side of the aneurysm, just to make sure that we are not going to produce any ischemia, because temporary clipping might be quite long in these cases. Now the aneurysm is punctured and decompressed, and only after this, the rest of the sac is dissected free, and the clips are applied, which are quite frequently multiple. You see the clips here. You see this M3 segment, the M2 segment, and what's important, that all those perforators coming from the base of the sac actually are free and patent. And this is actually the another M3 segment, and the neck was the whole M2 segment of the middle cerebral artery. In these large aneurysms, quite frequently one is left with the remnant of the sac at the bottom. Usually the aneurysm wall in this region is very firm and very thick, and it doesn't grow. So you may leave a piece of the aneurysm behind, and you may feel free that it will not recur. And as of now, we have not seen any recurrence in these large aneurysms which were treated in a similar fashion like this. You see that the Sylvian fissure is not opened only at the top. Actually, here is the skull base, and you work laterally from the sphenoid wing. Here are the perforators, which are very nicely preserved, and which are the important vessels in this area, actually, because you cannot do any bypass here. And here's the bypass. We probably should move to the bypass now. The regular STA, MCA bypass is usually sufficient. We hardly use the high flow bypasses in these cases. The 20 milliliters of blood which comes in 1 minute through such a bypass is usually sufficient. Let's go forward. Okay, and here is the ICG control. Again, the whole vascular tree is checked, whether everything is patent, whether all the vessels are having its flow in a proper direction. This is one of the M3. This is the M2. Here's the another M3 down at the bottom. You said that the brain is very nicely filled with blood. These are the perforators at the bottom of the sac, again working properly and as they should. And now we shall go again to the STA-MCA bypass, which is being filled very nicely. This is the intra-op MR, just to rule out any ischemia, immediate ischemia. I can confess that we did it in some 30 cases, this intra-op MR, but never ever did we find any ischemia, and never ever did we have to return back. So we do not do it too frequently anymore. Here's the post-op CT angio on the day of surgery, and this is the next day angiography. You see the base of the aneurysm left behind, and the frontal branches are filled by the original parent artery behind the MCA, and the temporal part of the brain is being filled by the STA-MCA bypass. The patient is doing well. The same thing is in freshly ruptured aneurysm. This is actually dissecting aneurysm, which I did not appreciate quite well prior to surgery, and surgery itself was rather not dramatic, but something different from what we are used to do. This is the sac of the aneurysm. You see how nicely it's pulsating. It seems like a regular wall of the aneurysm, which later on you will see that it was not. At this point, we already have M1 in our vision. We already have STA-MCA bypass performed on the temporal branches. Here is one of the M2 segments. Just beside is the other one. And now you see that during the dissection, there are strange layers. And then the aneurysm, without any prompting, nicely ruptured, as it will happen just now. You see, I didn't do anything, it just ruptured. Now is the time for the assistant to look for the second suction fast, for the scrub nurse to beep silently, for the anesthesiologist to be nervous. The blood flow is quite nice, but since I know where the M1 segment is, it's not really that dramatic because you can get there easily. You see, this is the M1 segment that you can put on the temporary clip just to quit the bleeding and go on with your dissection, feeling rather secure when there is the bypass in place. And during the further dissection, which you will see shortly, it was apparent that we really are dealing with the dissecting aneurysm, which means that we most likely will not be able to preserve the parent artery. You see that this is the M2 segment, which already is part of the dissection, part of the rupture. The wall, vessel wall is very insufficient here. It's difficult to deal with the vessel wall. And then suddenly then appears a strange layer for dissection, which is now, you see that I'm pushing actually the aneurysm away from the vessel. The vessels are here, both M1 and both M2s. Now this is nearly free. And now as the dissection proceeds, suddenly the whole sac or pseudo-sac is free of any attachment, and it can be removed to gain some space and to deal with the parent arteries, which in this case was a rather futile exercise, but you always try to preserve the original vasculature, and you wouldn't like to depend on bypasses only. You see that it was not really a small sac, quite a piece of pseudoaneurysm. And here is the original vasculature completely free of this. And here, now one needs to take a look where the ruptured wall is and whether there will be any possibility to do something about it. So it's quite a lot of dissection even now, and quite a lot of orientation. Here is the one M1 segment, M2 segment. Here is the clip on M1. This is the part of the sac which is free. And here the rupture in the vessel wall, which goes from the distal M1 into the proximal M2 of the frontal branch. So what we did, we tried to suture it, not really suture it, just to approximate the vessel walls, and then occlude the rupture with the clips, which finally we actually achieved, but as you will see, it was rather futile exercise, but you still can do everything from this simple approach. Here you see the hole in the vessel wall. Now I'm trying to approximate the walls with sutures, which quite frequently in these situations is impossible because the vessel wall is not really the firm thing, but very weak, and the sutures tend to tear out of it. But this is just for approximation. 2 or 3 sutures, then you see how it's closed, and then you may try to finalize the occlusion with the clip, which we did. And actually everything looked rather nice, but when we did ICG after this, the whole area was not patent. So we finished the whole procedure with the second STA MCA bypass from frontal branch being sutured to the frontal lobe, and this is the STA artery, the frontal branch, and the temporal branch. It's already sutured, and now we suture the frontal one. Sorry, let's go back. And we were lucky in that you see that the M1 segment is occluded, but the collateral flow is rather nice. So probably it was something like a longer lasting, even with not really well established flow through the MCA. And here are the 2 barrels of the bypass filling the both territories, both frontal and temporal. This is something strange at the 6 months follow-up, that on angio, the temporal bypass is filling nicely the temporal lobe, but on the reconstruction, you see the frontal part of the bypass is filling the rest of the brain. So just to summarize this, opening the basal cisterns and dissecting the whole vascular tree is nothing really that difficult, because all the structures are in the anatomical position where they should be, and when you saw them in the laboratories in all the textbooks. So you can see almost everything at once, you know, starting with the internal carotid artery, going to MCA, and you are here at M1-2 division very soon, going laterally to the ACOM area, again, very nicely seen. You go downwards along the PCOM on our side, you see the P1 again on our side. This is the basilar artery and superior cerebral artery. The opposite side, P1, which is thin, and this is the opposite side, PCOM. When we enlarge this a bit, you see the oculomotor on our side, oculomotor on the other side, and you see how nicely it matches. Here is the fetal type of PCOM on this side, and you see how nicely it matches in the actual side. So you can dissect all this, and you can occlude almost any aneurysm which is in this area, including, from one approach, you can occlude both middle cerebral arteries and another 3 aneurysms on the way. So this is possible, but sometimes this is too much, and sometimes you would like to divide, let's say in mirror surgeries, the operation in 2 stages. I don't know if Matthias occluded both those ophthalmic aneurysms, which he has shown it. I didn't understand it well, but he probably did it because it's rather possible by drilling on both optic nerves. So this can be done, but I still prefer doing the single aneurysm with single approach, and if there is a mirror one, then with another. Considering the endovascular treatment, I do not really care by which means this aneurysm is occluded, whether by coil or clip. What's important that the post-op angio shows patent vascular tree, patent vasculature of the brain, and as long as the patient is symptom-free, that's important. And this is something you can achieve with this minimally invasive or minimally aggressive approach in middle cerebral. So I'm back to our articles about the MCA and the ACOM aneurysms. You see that there were like 400 MCA and 300 ACOM aneurysms. And the ratio is just the opposite, 4:1 surgery to endo in middle cerebral and 1:4 in ACOMs. The results in unruptured were like 3% morbidity mortality in unruptured for surgery and 10% for endovascular, which is rather high. It's not statistically significant, but still, this is too high a number for unruptured aneurysms. In ACOM, it was 0 versus 1.5. ACOMs are much better in this respect. In ruptured, it was 11 and 14% morbidity mortality in ACOM, as opposed to middle cerebral, which was 35 and 48 in endovascular. Actually, this is given first by our policy. Any aneurysm, first we treat the aneurysm, then we treat the patient. So we occlude the aneurysm as the patient comes in whatever condition he is, in whatever timing he arrives. And the morbidity mortality in middle cerebral artery aneurysms is these intracerebral hematomas, which undermine the motor strip, and the best achievable results for the patient is hemiplegia. So some final remarks. Consider the length of M1 segment. The longer the M1 segment, the better. The easier the approach, the more surface the aneurysm. Check the direction of the aneurysm sac. If the sac points frontally, start on the temporal side, get to the M1 on the temporal side, secure the distal M1, and then go for the aneurysm. If it faces temporally, it's of course the vice versa, that you come from frontal side. After the arachnoid cut, you just follow any artery as far as distal M1. It's obvious and regular policy. Some aneurysms may virtually be on the surface. I even have seen several middle cerebral artery aneurysms which had adhesions between the sac and the sphenoid vein, which may be a problem sometimes. Check the neck circumferentially and check this area for all those pre-aneurysmal formations and cover them with some cottonoid or whatever is in your armamentarium. And inspect the situation. That's what I've been saying, that sometimes you need several clip adjustments, changing the clips, multiple clips. Middle cerebral may be quite complex aneurysms. On the other hand, the more clip adjustment, the more you call for complications. So once you have to be satisfied and once you have to be done with your aneurysm clippings, don't overdo that. Don't want to have like a really ideal position of the clip. So in conclusion, MCA aneurysms are dominantly surgical. In our institution, we do not discuss middle cerebral aneurysms with endovascular people anymore. We show them the aneurysm, but we do not ask them for the treatment. It's a really surgical disease. The minimal invasivity in relation to the brain and to the vasculature is easily achievable. Once you learn the dissection, you get there and you are done within 30 minutes. Any MCA aneurysm is suitable for surgery. We even check like that dissecting aneurysm. We prefer to go for this surgically, because if you need to occlude the parent artery being occluded by the clip blade is like 1 millimeter in width, not more. So you can put it outside the perforators. If you need to occlude the parent artery endovascularly, you need some 10 millimeters artery length, and you endanger the perforator. So it's much safer and much more logical to do it surgically. And if you perform the bypass, why shouldn't you look for the aneurysm itself? So these pseudoaneurysms, fusiform and dissecting aneurysms are difficult to treat. Endovascular treatment fails very frequently, and bypass techniques are a must. You really must master them, and then you may do whatever you want with the aneurysm. Let's see the Ramesh, do I have time?
You have almost there. Kasar, is that right? I think it's almost.
Yes, correct. You have 2 more minutes.
Well, I don't need them. That I'm nearly done. This is the statistics of my department in aneurysms since 1956, and you see that we leveled out somewhere at 40 aneurysms being clipped per year. What changed dramatically in 2000 was the introduction of endovascular techniques. We now have like 120 aneurysms per year. relation is like 2:3:1, endo versus open. But in open surgeries, definitely the middle cerebral artery aneurysms are dominant. They are the first which are being clipped. The number 2 are ophthalmic and PCOM, of course, and ruptured pica. The distal MCA aneurysms, usually fusiform, exactly the same, directly to the aneurysms through the fissure, occluding, in this case, just clipping and resecting using the bypass. This is the post-op MR in this case. And the last aneurysm I'm going to show you, it's a large MCA aneurysm. And again, you see the number of clips you need to occlude it. You need to preserve all the perforators. You need to preserve parent arteries as much as possible. And you shouldn't worry about the possible aneurysm sacrum, which never grows because it's a thick wall, which is just okay. That's it. Thank you.
Thank you so much. Thank you very much, Vladimir. Excellent lecture as usual. Huh?
Thank
Good.
you.
We have a few questions here. One of them coming from Keki Turel. Yeah.
Hi,
Do you always
Keki.
use, yes, he's asking, do you always use a temporary clipping procedure? Does the length of M1 make you decide for or against these?
No. Actually, it's in less than 25–20% of the patients. In majority of cases, I go directly to the for the aneurysm. If the sac is large, I either use a temporary clip, and the option is adenosine cardiac arrest. One of these two, but this is really individual, KK. So I'm not using the temporary clips routinely. I'm using them whenever needed, whenever I feel that the aneurysm should be somehow secured before clipping, but it's not that frequent. No.
Okay. Good. I have one more question from Mohammed Yusman. He's asking, is it always necessary to coagulate aneurysm after clipping? What is the difference in outcome if you coagulate or not?
No, there is none. There is none. There is no difference in immediate outcome. But if you really coagulate it, then you kill the aneurysm. And I once have seen the clip failed 2 years after surgery. Suddenly the clip was open, and there was not the whole aneurysm, but the part of the aneurysm was filling again. And I don't want to have any relapses, nothing. And I have the feeling that if you coagulate the sac, you are left there with a piece of scar tissue which holds the clip better. So this is the reason.
Okay. Excellent. Last question. Other questions, please, if you can consult the Q&A and maybe reply directly to the people. There is here another question. What is your strategy with incomplete neck clipping?
That's a good question, and that's not that seldom in MCA aneurysms because they are complex. Okay. Should I know about it, then I cover it with a piece of cottonoid, because not in all MCA aneurysms you are able to clip them completely. If someone would tell you that he clips all the MCA aneurysms completely, don't believe him. And then there is and I feel rather comfortable with cottonoids. The other issue is that in few cases I've seen like dog ear after the clipping on a post-op 3D angio. You wouldn't see it on the normal angio. You would see it on 3D angio. And actually, I did nothing. I just left it behind, and we are following the patients with CT angios. And until now, in 20 years, probably, when we have really well followed the series, there was no relapse of the aneurysms. Relapsing, we did a study in our series of nearly 1,500 or 1,600 aneurysms of recurrent aneurysms, redo procedures. In surgical, series, it was 2.8% in the whole series, where we needed to repeat the procedure. And it was either incomplete clipping in half of the cases. In another part, it was my decision that I saw that it would be irresponsible to try to clip the aneurysms, and we went directly for endovascular procedure. And in another two cases, those were the subpulmonary bleedings before the dura opening. In that case, we went away. On the other hand, there were nearly 13% of redo procedures in endovascular series, which is quite high. And we didn't see any long-term relapsing aneurysm. You know, all these which we had to redo, these 3% of cases were fresh. So I believe that we probably are doing rather proper work, since we do not need to reoperate or re-intervene in these patients.
Thank you so much, Vladimir. Thank you very much. So for the audience, if they still have some questions, please go ahead and ask them on the Q&A, and Professor Benes will be very happy to answer them. Okay.
I will.
You could answer to everyone so that everyone gets benefit from the answer.
Yes, thank
sure
you.
will. Don't be afraid.
Okay. Let me introduce my friend Eka. I'll try to pronounce your surname. Waijohe Pranomo. Is that okay? I don't know if I passed the exam. Eka is going to present us and talk to us about wisdom in management of giant aneurysms. Thank you very much, Eka.
Hello, thank you very much. Thank you, Kasadi. Thank you, whole friend and family of the Anatomy Committee and all participants. So after we listen so many fabulous lectures, anatomy and the other from previous speaker, let me share with you what is the purpose of all of the studying anatomy and skill and technical. So at the end, after we learn about everything, at the end, we need to decide what to do, how to do, when to stop, and when to say the option. So finally, we need the wisdom before we decide what to do for the patient. Because we are consultant and the patient and family will select what they will need to be done. Okay, I start with my PowerPoint. Okay, thank you very much.
The base is a 1,200 square meter
in
terrace
Indonesia, we have
with
two
6
giants.
tiers.
One is the giant Buddha temple, the
walls are
largest in the
adorned
world,
with
and
numerous
giant
Buddha reliefs.
lizard called Last Dinosaur. So after watching this movie, please come to
The total
Indonesia
length of the
after
galleries
Corona
were
gone.
placed en-
So this is my institute, my medical school, my hospital, and we started here in 1996. Then we developed microsurgery in Asia, start from this hospital. And this is my teamwork. So in Indonesia, we have 17,000 island, and we have about 40 hospitals, and we need to manage the neurosurgeon working in my team. We have so far 26 neurosurgeons working in the remote area. You know, from here to here, we need to fly 9 hours. So we need to make a team to build and to make them develop. So this is our experience in managing giant aneurysm. We all know that the definition is larger than 25 millimeter, and it's about 5% of all intracranial aneurysm. Sacral aneurysm during the lifetime may rupture and may also grow to reach the giant proportion. And fusiform aneurysm also show the same. And both can build so-called a giant aneurysm. So the history is different, the pathophysiology is different, and the treatment also different. That's why we need to know their character, their habitat, and also their threat to our patient. Pathognomonic finding of giant aneurysm, there is always a broadening of the parent artery, splaying branch in the neck, and sclerotic and also calcification in the neck and in the body, and also mural thrombus, which we need to know before. So the natural history, this is the annual risk, and this is the rest of recurrent hemorrhage after initial SAH. Sorry. So decision to treat giant aneurysm, we need to know, and the young generation also need to understand that not every abnormality in the imaging need to be treated invasively. I will show you the cases later on. So the decision is dependent on the age, the location, mass evac, and clinical presentation. And again, we need to remember that we need to do our best for the patient. Best does not mean always invasive treatment. So the need treatment if the patient have a hemorrhage, progressive headache, worsening of the nerve palsy, and enlargement of the aneurysm, and also seizure. I try to draw an algorithm about giant aneurysm. So giant aneurysm, the patient come to us with impending rupture or bleeding. And what need to be done? The option is embolization or surgery. And surgery may clipping, may trapping, with maybe without bypass. And sometimes the patient come to us with a mass evac. If the patient comes with a mass evac, the answer is surgery. Again, I show you later the case. And I put here the question mark, means that do we need to do something in the patient in front of us? So this is the pre-operative planning. I like very much to come to the CT machine and make a simulation. How is the craniotomy? How big is that? Because in surgery of giant aneurysm, we need to see the thrombus position, and we need to see the position of the parent artery, the distal side, and also the proximal side. If possible, we need to see both. That's why the craniotomy need to be sufficient. Does not mean always small. And sometimes it's artificial from the coiling, and sometimes it's balloon test or ligation test. So there are many roads going to the room, maybe clipping, constructing, trapping, coiling, decompression, etc. Principle of giant aneurysm surgery, and we need to approach maximize exposure. So we don't use minimal invasive for this giant aneurysm, because again, we need to see the proximal vessel, the distal vessel, and the surrounding structure. And also we need to do great operative exposure. So young generation need to learn a lot about how to split Physician fissure widely. Yeah, again, in giant aneurysm, mostly we need a wide splitting of the Physician fissure to have a beautiful exposure. And again, we need to remove anterior clinoid, like a Matthias showed us, and we need also to learn about orbitozygomatic osteotomy, where this approach of craniotomy, we can have a beautiful and large exposure, and we don't need to retect too much in the temporal lobe. And of course, simulation of the proximal control is very, very important, because most of the time we need a temporary clip to do permanent clip of the giant aneurysm, mostly because it is complicated. The body is very tough. We cannot see like a normal sacral aneurysm. And prefer to use a multiple or in tandem or parallel. Never use single clip in giant aneurysm, because again, the character of giant aneurysm, the wall normally very thick, sometimes the thrombus inside. One clip, there is a danger of slip to the parent artery later on. And of course, they will be very dangerous. And this is the surgical morbidity. Be careful because we are so busy about manipulating the body, then we forget that then prolonged temporary clipping sometimes cause worsening and of course occlusion of the parent artery. So again, also sometimes be careful, premature rupture make a worse thing because as age will more that and means morbidity will be more that. So I start another cases with several cases. Number one is this is the conventional clipping. 50 years old female from Bali Island came to us with a severe headache. You see here there is a subarachnoid bleeding in the medial, and you see here the shadow of the giant aneurysm. And you can see here this is a CT angio, the giant aneurysm, very typical. And of course we need to clip this. This is IC, this is A, and again this is very classic. We need to just temporarily clip the proximal and distal, and then we suck the body of the aneurysm. We can see here immediately aneurysm will collapse, and we have time to clip permanently. And in this case, we prefer to use a multiple ring clip. So again, we have time, couple of minutes to clip permanently. Then we need to remove soon the temporary clip. And at the time before ICG era, I used a Doppler. So don't worry, a young generation who work in the place that you don't have ICG, you may use Doppler. Doppler is very cheap and very powerful, very good information. And we check with the parent artery after clipping. You can see this is the very good artery or not from Doppler. So this is another case of the giant IC aneurysm, 41 years old male with a spontaneous edge. And you see here, this is the aneurysm. And we need to have like a simulation first, okay? This is, you see, this is M will be here, A will be here, and IC will be here. So if the craniotomy coming from the Zilvian visual, we will see M, we will see IC, and probably we will not see A1 because again, this is a quite tough body. When you see from here, it's difficult to make it collapse sometimes. Then what I did in this case, this is like a variation I doing with my assistant. Then after I clip N, M, IC, I ask my assistant to suck with a puncture of the body aneurysm as strong as possible. Then I have time, couple of seconds to clip this. You can see here, this is the IC, this is the aneurysm. I can clip IC, but I can't see A. So again, I need to suck and then clip it permanently. So this is a third case of giant ICPC aneurysm. And this case, because of the probability of bleeding, when we clipping, we need to do bypass, and we did bypass to make sure and to make the procedure easier and actually more secure. Because again, when we manipulate aneurysm, when we are not secure, we need to do bypass to make another alternative artery before we doing clipping. This is giant IC ophthalmic aneurysm. So 40 years old male came to me with worsening of visual with a bitemporal hemianopsia post-coiling. So you can see here, this is the coiling about 3 months before he met me. Somebody coiled the aneurysm, and that's correct. And this is beautiful coiled aneurysm. But 3 months later, the patient come to me, he said to me, doctor, my visual actually becoming worse. And when we check, yeah, there is like a very poor recent bitemporal hemianopsia. When we check with the DSA, we see here there is a recanalization. There's so the blood coming again. This is the risk of coiling. So what to do? The patient come to us with the compression syndrome of chiasm. So we may do recoiling, we may do removal, but I don't think we have time. If we, for instance, recoiling, because when it's coiled, it needs times to make collapse. right? And the problem is now how to decompress the chiasm as soon as possible, because he got a poor visual disturbance. So what I did, we have to remove. So in this case, we need to do again large Sylvian fissure dissection here. We can see this very beautiful. And again, remove clinoid anterior. So removal, because we need to have space to see the proximal side. This is the body of the aneurysm. So I need to clip so the proximal and distal side with a temporary clip. And as a conventional treatment, I suck the body of the aneurysm with a puncture. But you can see here, there is nothing changed in the body. It's not collapsed like in the former case. Then I decided to permanently clip here in the neck of the aneurysm, and again remove as soon as possible the temporary clip. Then of course try again to puncture, but again nothing changed. So I need to do something. There's something annoying, of course. Then we just open the body of the aneurysm. You see here, this is of the coil before, and then inside we cannot collapse the body because of the coil. So again, we need to remove whole the coil as much as possible. Be careful. You see here that the permanent clip going to the peroneal artery, if we are not pay attention, that's very dangerous, right? Again, in the giant aneurysm, the clip may go to the peroneal artery. So anyway, after clipping, removal the aneurysm, then we can do total well clip of the body aneurysm. This is the 50-year-old male with a worsening of the visual acuity with a bitemporal hemianopsia, post-trapping somewhere, I do not know. So you can see here, this is a common aneurysm. You can see here, this is the aneurysm, this is the ACOM, and this is very, very thin chiasm. Can you see here? So again, this is, we need to decompress because the patient came to us with a compression syndrome. And this is because the chiasm very thick like a paper.
Sorry, Eka, 2 more minutes.
Okay, then I need to clip and then just decompress, not whole. We don't need to peel the body aneurysm because it's very dangerous. Just decompress, just remove the thrombus here, then because we want the function of the eye becoming better again. So this is not the case. Very typical 12 years girl with the SAH with a seizure. You can see a very rare case with a, this is the aneurysm, super giant aneurysm in the left side. Here, you can see here. What to do? She came with a SAH. So we need to study about the vasculature because this is a very young. So we believe that the aneurysm was there when she born. So you need to see here, when we see the angiography, so the anterior communicating and then arterial cerebral give a supply to the middle territory. Then what we did here, we need to open this large enlargement of the Sylvian fissure. Again, you know, we can see here, and then we need to check everything here. We can see here about 6 centimeter giant thrombus aneurysm. Here is A, here is M, and I need to clip the M as distal as possible to the aneurysm. And in this case, we need to open the aneurysm. Then this is a quite unique because you see that we cannot explore at that much because this is a left side and she was a perfect. So what I did, I just clip and then we just remove everything from inside. Then I just clip the aneurysm from inside. Again, because in this is unique case. If we clip from the outside, we need to dissect too much. And again, this is the patient still very good. Means I don't want to damage a normal left side cortex. So again, this is a removal of the thrombus aneurysm. Then we clip from inside. Again, important. This is different. From inside means that I don't need to dissect. I don't need to damage the surface of the normal temporal in the left side. So this is a very unique case. And again, after removal, as much as possible, there is still bleeding inside. You can see here. Then as quick as possible. We need to do with sometimes with CUSA of the thrombus. Again, this is the bottom of the aneurysm, and here I clip using a permanent clip from inside. So this is another case of giant aneurysm, very big, and theoretically we plan to do actually flow diaphragm, but this is not as beautiful as the theory, because again, my colleague doing this more than hours until this red line here means that radiation is too much. So flow diaphragm is filled, and finally we decide for her, okay, she accept that she got the ophthalmoplegia, but as long as the aneurysm not threaten the life, she accepted, and so we don't do anything. This is the ischemia after long time manipulating from endovascular. This is not the case of the fusiform artery. We clip, but the result is the patient will not wake up until while you're in ICU and die. So again, we need the wisdom. We need the wisdom what to prevent. This is a very big aneurysm. You see here, there is no neck, and we just said, okay, just stay home. And finally, he died mercifully without ICU, because ICU in Indonesia is very expensive, $1,000 per night, and the patient did not cover by insurance. This last case of the national golfer. You can see here, he
1 minute, Eka. 1 minute.
Okay, I'm going to stop. So sorry, this is the very untypical dizziness. This is the aneurysm. You can see this is almost total thrombus aneurysm. So what to do? He is a national golfer. I said to him, okay, just come and play golf. Come to me in every 6 months, per year. We check if the aneurysm not enlarged and the parent not occluded. I prefer not to do anything in this case, because almost no symptom and the aneurysm is almost totally occluded. I thank you very much for your participation.
Thank you so much, Eka. Wonderful. Excellent presentation. I have just one question because of time from Joaquim Perez Zabala. Is asking, if you have a patient that presents with a rupture on an M1 giant aneurysm with hematoma that stops the bleeding, you will first approach through the Sansylvian approach and evacuate first the hematoma, or you control first the proximal aspect of the M1 and then later on evacuate the clot?
Thank you very much. It's a good question. So it's also depend how big of the hematoma and where is the location. Is it in the left side or is it more in the neck side? If the hematoma is near the neck side, yes, I agree. We can remove the hematoma first and then clip. If the hematoma is in the left side, well, we need to understand what is the risk of the removal of the hematoma. The risk is that will be like a premature rupture. Then what to do? We need to have a best assistant. Okay, best assistant means that the suck, maybe you need a 2-3 suction, because when the bleeding coming during the dissection, you need somebody suck the blood coming out to see everything clear, and we need to see where is the neck of the aneurysm, or at least to see the M1, then we can see temporary clip. So again, important is tactic. And again, the assistant, don't do anything yourself. It's too dangerous. You may shock when the blood coming 4 liters in the surgery. Thank you very much.
Yeah, that's fine. A quick short one from a resident. Do you need to trap the distal part of the giant aneurysm when you open the sac thrombectomy to prevent embolus?
You talk about the young girl case.
Yes.
Yeah. So we cannot do thrombectomy before we identify the parent artery. Again, it's dangerous. When the bleeding is profuse, then we are not ready. So we only do thrombectomy if we already identify where is the parent, and we already try to use a temporary clip. So if something happens, we definitely need to do temporary clip, or we can do temporary clip and then thrombectomy. So again, do thrombectomy after we identify and we sure that we can do temporary clip.
Fantastic. Thank you so much for your wonderful lecture, your wonderful presentation.
Thank you,
I'm going now to let Hype to introduce the other two presenters. Thank you very much, Eka.
Thank you, Kasari.
Hype, you can take over.
Miss.
Hype, are you there?
Very good.
Hype? Hype? Let's see.
He was there.
I'm here.
Ah, okay.
Let's see if I should be there. 1 second. Hype? He was around.
Hello? You hear me?
Hype? Can you unmute? Just call me 1 second, Kasadi. Let me ask him.
No problem.
Hi, Hype. Can you start with the next two speakers?
May I start?
Yes, you can. Hype, you want to start the two speakers? Can you hear us? Hype? I think Hype is on the phone, so maybe it's not. Giovanni, just give us 1 minute so I could come back.
Okay.
Sorry, Ramesh, I think you just go ahead because of the time. I think later on he can have the final one. Yeah, that's the project proceed.
I'm good to go. I'm good to take over. I'm supposed to moderate, yeah?
Yes, you can. I think next is Giovanni Brogi.
Okay.
Okay.
Very welcome, Giovanni.
Thank you.
I'll be in the background. I'll listen to your talk. I guess next is Igor, I guess.
After that, yes.
Okay.
Yeah, sure. Okay, Giovanni, go ahead, please.
Should I share the screen?
Yeah.
Okay. Here we are. Okay, so after hearing, please let me know 3 minutes before the end of my time. Let's thank you everybody. Good afternoon for everybody. For my side, for somebody of you, it will be morning or evening, and this course is very exciting. And after heard for many lecture the role of the artery, I try to put some accent also on the other side of the moon, on the Venus. So nothing to describe for disclosure for this presentation, and compliments, of course, to our master that are doing everything. ICG, it was shown by Vladimir and from others, is on all the drugs that was used by ophthalmologists and now is using for a cerebral pathology. Is a drug. It binds with the globulin in 2 seconds and remain intravascularly. Will be excreted by the liver and stay for 3 to 4 minutes in the body. And the dye can maybe administered more than 1 time during the surgery, and that is very important. You need to use it a dedicated microscope. This is the one brand, but also some other brand like Leica and Olympus and can do this same things. So what you see this the vessel, the artery and venous time. You can use the region of interest, and you have the color. That is quite important because the color is making you the speed of the circulation in this particular malformation, and you can have also some objective measurement. This is our experience with the ICG in Milano. And this is one case that I showed my guest last time, is about a DVA of the petrous vein. And it's quite important when you see in the MRI to know the relation between the nerve and the vein and the petrous vein and the artery that is offending the nerve, and that you can move. Let's forget this one and let's go to AVM. That is our experience. 69 patient. You see here that the Spetzel-Martin grade is quite different. Of course, most of them were in a 1 and 2 grade. Some cases were embolized before. The ICG was used always pre and post, and in some cases we use the ultrasound and the fluorescein via the angiography that we will say later on. So what is the importance during the AVM? Recognize the feeders, explore the effect of temporal clipping, check the residual shunt at the end of resection, and evaluate the AVM perfusion after surgery, because that's give you, before I wake the patient, if you will have trouble or not, and also establish the venous drainage. Look, this is very small temporary AVM you see here, and you can judge the same amount of speed of circulation. You find the feeders, you know the drainage, and that is what is helping you. Another, and this was very simple case. What about a very more complex case? You see here, you cannot see with the visual on the microscope which are the feeders, which are the drainage. And if you do the ICG, you can really appreciate the temporary difference. But that stay in your eyes. You cannot discuss with your assistant, you cannot discuss with yourself. If you have this kind of a flow 800, and you can measure the blood flow in a different compartment of the AVM. And if you want to know also the deep situation, you can have another way of video angiography, that is the ultrasound with the contrast medium. And you see here, you can see the bottom of the AVM and to judge. That is quite difficult. We have to appreciate this one and to learn how to do it. But that is a very great tool in my experience and in my prevision. Here we have another small AVM with hematoma. And again, you can appreciate the pre and post blood flow, not only from the artery that changed completely the speed of circulation after the removal of the AVM, but also the venous drainage that is safe and is changed completely and come back to normal. And that is quite important just before closing the case. And here you can make all the measurement as I told you before. Check the residual, check the residual shunt. You have here the embolized, partially embolized AVM, you have the remnant, and you can make the temporary clipping and check what does change the temporary clipping in this particular situation. And you see here that the speed of the different compartment is completely changed. You can appreciate it with the color and this in this more objective way. Evaluate the perfusion after the surgery and the venous one. And that is, again, at the end of the surgery, you can see that the circulation of the healthy brain tissue is normal, as you see here with the color, and that is the ICG from which the color analysis is done. And when you are at the end of everything, you can check if everything is done well. In this situation, that is the same case that I showed you before, the venous drainage is completely come back to normal, and the circulation of the feeders is come back to quite the normal situation. Again, another case, a very small AVM, that's before the surgery. You see here that it's very difficult to understand what are the venous drainage. Here is completely arterialized, and after the surgery, here you cannot appreciate the speed of the circulation, but here it's come back slowly toward the normal circulation. So that is the advantage of using video angiography in AVM. And that's this. Let's escape this one and go in this way. The progress analysis before and during the surgery is quite important, and it changed completely the strategy in 6 of the cases because of the clipping of the feeders, and recognize that that was the good way or the bad way to assess the surgery. And the terminal assessment is quite important because, as I told you, first of all, you can, in 3 cases, we had expect a residual nidus or a residual AVF shunt. And in 21 cases, we have a normalization of the arteriovascular flow in the disposal area. That is quite important. Does this video angiography add time to the surgical time? This answer is almost no, because 8 minutes for the classic video angiography and 16 minutes if you do also the analysis with the 800 A-flow. So it's in a surgery that is last at least 3 hours is almost nothing. Conclusion for the EVM, the superficial survey is quite important, mainly when you are not so used to the AVM surgery, but each AVM is completely different of the other one, so it's a kind of tailored survey. The progress analysis is quite important because you sometimes you don't understand, you get lost on the periphery of the AVM, and it's quite important to understand where you are going. And the terminal assessment, as I told you, is quite important to know if there is complication. You have to expect complication, and you have to expect complication or deficit for the patient. Other case, the other way to do video angiography, there is another fluorescence system that is fluorescing. Fluorescing is a dye, is not a drug, and is getting again from an ophthalmologist experience. The only thing is that is very important to know that is for vascular side. You can visualize very well the vessel during the surgical procedure, but that is also true for the tumor surgery, as I will show you, not only for taking out the tumors, but for the venous respect. Cohen Gadol was the first one that uses this video angiography, and some other friend from Japan did again as in a similar way. The very important things is that you can do this fluoroangiography only one time. While ICG, you can repeat it 3 or 4 times during the surgery. This one is only one shot. So that is the important limit. About surgery of the aneurysm, that was a clipped aneurysm, a check for the parental artery. You will see here the video angiography. You see the perforators that are more evident than with ICG. Nevertheless, ICG remained the gold standard for aneurysm surgery, as was shown by Vladimir and from others. Another case for irregular MCA aneurysm. I'm sorry that this is due in a three-dimensional, so you have to look only one side of the screen. The dissection is as usually. After Vladimir, I'm going very fast because I cannot add anything. It's just curious to see the aneurysm exposed is to be with two parts of the aneurysm. It's very complex aneurysm, and of course, when you are exposed that, you can do as usually the, let's see, to be short. I don't want annoying people of the dissection that is done in usual way, sharp way, with the forceps, and you can put the first clip, and of course you're not as many times happy of that, so you take it out, and you put another one in different shape. But what is important for us is not the clipping, but after the clipping, and you put the clip also to the other part of the aneurysm, is the ICG that they check if the parental, if you did a very good things. Of course, you can use also the Doppler, that is quite useful, but from the pleasure for your eyes and for the real post-operative situation, that is quite important. This is the ICG. You can make the control with all the analysis of the speed, and this is the fluorescence. And you can see, you can use both. The problem is that if you have one microscope with one system or the other one, you can use that. That is the control of the after the 12 months. This is another interesting situation. The dural AV fistula in the temporal lobe, at the tip of the temporal lobe. Again, this one too is done in three-dimensional. You see here the sharp dissection to expose the fistula, and you got there, but you can be sure of what you did only if you perform ICG. And you see here then the blood flow in the fistula. So that is what you can do. You can also do with the fluorescence, is the same things. You will see here that now the artery time, and the fistula is coming immediately after. Of course, you clip the fistula, and after the clipping, you check again with ICG. And you coagulate the
Giovanni, we got 3 minutes more.
Okay. So, and that's his postdoc. That's for oncological neurosurgery, very fast. What can be used? This is a GBM. This remnant of artery is working or not working? Yes, it's working. So that's your help. Let's go for another very interesting case. You have here a Rolandic gliomas, and you get a drop of the motor evoked potential. And you can see here that the ischemic region is coming out. What to do? You cannot leave the patient like that. You make all the control, and after that, you decide to do a intracranial bypass. And you see here that bypass is running well. This is the picture, but you can see here in the movie. And that is another way to improve the quality of life of our patient. What about let's forget this one, and let's go for the meningiomas. It's important because they can tell you if the sagittal sinus is open or not. In this case, you have a bridging vein, and the sinus is closed by the meningioma and by the thrombosis. You can check after the removal if the veins are present or not, and what is the speed of that. And that is other things. There is fast draining vein, like this one, in which you can see that there is only one drainage that is going to the sagittal sinus. In a very similar situation, you have a completely different drainage from the vein. So you have to understand that there is one fast vein like the previous one, but you see here that later on you will have a full of other drainage. And that is something that may change your strategy. The temporary clip, you can put a temporary clip on this situation. This is a fast draining vein. You see here, the drain is only, there is no circulation outside of this drainage. Nevertheless, you put a temporary clip, you perform ICG again, and there is no circulation. So this vein cannot be sacrificed. You have to avoid anything. Another situation, a little bit more complicated. You see here, like in the previous case, that you have one major drainage, but you have also some other vein collateral, and you see here the color of that. So you do the clipping, and that is something very important. After the clipping, you see that the major vein is closed, but there is a circulation here that is make the drainage of this part of the brain very good. So the hypothesis is that there is a common chamber, and that the fast draining vein are going directly. If there is no slow draining vein to drain, it is completely different situation. And that's the scheme. If the clipping test is negative, you have to save the vein. If the clipping test is positive, you can sacrifice the vein. So at the end, this is our conclusion. ICG video angiography, mainly with the ICG flat blow, is very useful in AVM and tumors because it allows you the study of the parental artery and the hyperperfusion after the when you perform the surgery, and you can make a bypass or do something to improve it. Vein can be arterialized, and there is fast drain and then slow draining vein, and that is you can choose if the sacrifice is possible or not, and that is making with the clipping test the simple, stupid situation, I think, but very useful, and that is very important. And the new fluorescence guided technique has to be let's say improve and confirm it. That is our group that you see here around, and I thank you for your attention.
Thank you very much, Giovanni. Excellent talk. I would ask some questions that on the chat.
No question.
No questions on the chat actually. So
that means that it was a very poor presentation, very not understandable presentation. Thank you.
There was a question, Aip, on the chat window.
I'm Dr. Kong from Japan, Tokyo, Japan. I want to ask a question. Do you use the ICG for brain tumor surgery? Because I do brain tumor surgery so often. So how do you evaluate the vascular change due to edema or compression of the edema or brain swelling or compression? due to the tumor. How do you evaluate the venous drainage?
Well, you can only study the speed of the venous drainage. When you take out the compression from the tumor, if you spare the vein, you have to understand they are working or not. Anatomically are working, but you have to know also functionally are working. What about the edema? That is not changing the performance of the venous drainage.
Okay.
Well, there's another question. Thank you, Dr. Takashi. There's another question from another person who says, in developing countries, there are no ICG or Flow 800, and what should they do? Would you like to answer that, Giovanni?
Yes, that is the major limit of this technique. Because if you have just let's say, normal microscope, you cannot do these kind of things. But the only suggestion they can do is the clipping test. You can do it, and you can see if there is change in the surface of the brain. For the AVM, is the same things. When you put the clip, you can learn from the experience of the people. Like we are lucky to use this technique. You can learn how to manage. You can learn a little bit more, but that is the limit of the economy in the world. And I think that I'm very sad for my colleagues that they cannot have this kind of tools.
Well, for that part, I can say that I am in one of the most poorest countries you can think of. I'm in Nepal for the last 13 years. I mean, I'm moving right now, but at least for the last 10 years or more, I've been using ICG. I've been using ICG from 2010 onwards for sure. So it is not exactly developing countries. You need to try hard. It's very important to get these ICG. Otherwise, before that, what we used to do was temporary clipping. Temporary clipping would sometimes help in decision making. Small temporary clips on vessels would help. I would not elaborate on that. Excellent talk. Thank you, Giovanni.
Thank you. It was my pleasure.
The next presenter is Igor from Toulouse, France. Is Igor here?
Yes, I'm here. Hello, Ike. Hello, everybody.
Hey, Igor. Yeah, good to see you.
Good to see
Igor is one of the best teachers of neuroanatomy. He is a neurosurgeon who does interventions as well, and he's been for a long time. He's been one of the mainstays for WFNS Neuroanatomy Committee, teaching excellent neuroanatomy to all the members as well as to the rest of the world. So pleasure to introduce you. Honored. Igor, please carry on.
Thank you, Ike. Thank you very much. As you know, it's a great opportunity. It's a real pleasure for me to be part of this webinar. Do you guys see my screen?
Yes.
Okay. So let's start with a question. I'd like you to take a look at these scans and tell me who needs an angiogram. We have here 4 different patients, oral vein or trauma patients. So who needs an angiogram, or all of them? All of them are young men victims of trauma. We have here a CT scan, bony window. This is a 23-year-old man. I'll show details later. He suffered a closed head injury after a car accident. So we see some liquids inside the paranasal sinuses, maxillary sinus, sphenoid sinus. There are some skull-base fractures. And then we have on the top of the left a gunshot which crosses the midline. And then in the bottom and left, we have a young man that was complaining of vertigo after a fight in a bar. And then we have extradural hematoma, classical one. So we'll come back to this case later. So this is just a provocative beginning. So traumatic vascular lesion, they can be didactically classified in 3 large groups. There are iatrogenic ones, open and closed ones. The open are evidently the most direct, obvious ones. But iatrogenic trauma is getting a little bit more common now, since endovascular and endoscopic techniques are getting more common. So in endoscopic surgery, a classical mechanism is directed trauma, dissection, or heating of the carotid artery during drilling for endonasal skull-based approaches. In the endovascular domain, most typical cases are carotid and vertebral dissection with angiographic catheters, intracranial dissections or vessel perforation with microcatheters, microgadgers, balloons, during remodeling technique, for example, to protect the neck of aneurysms. And for closed injuries, there are also different forms of presentation. We can have isolated intimal dissection, dissection with dissecting aneurysms, pseudoaneurysms, and even traumatic arteriovenous fistulas. So in the right, we have here some examples. So the first one is a traumatic, non-iatrogenic dissection of the internal carotid artery just after the bulb. This case has a very typical aspect, often described as a candle flame or a pencil, and all contrast that is injected in the common carotid artery is going to the external carotid. So there is no opacification of the carotid siphon here. At the right, we have another case. We don't have a candle flame aspect, but it's also interesting. It's an older patient, and we see there is penetration contrast inside the lumen, but it stops, and then you have some contrast stagnation also. You see that most contrast is gone. It was already washed from the external carotid territory, for example. But then there is still contrast inside the bulb. And then the artery gets narrow. And you know that in this site, you have a kind of this hematoma in the wall of the vessel. And you have contrast getting inside the false lumen. And then finally, you get the true lumen back here. And then you see there is quite normal opacification, and then it's stopped again. So it's important to keep in mind that this is aspect sometimes we see during thrombectomies. It's important to keep in mind that the dissections are embolic in nature. So that's probably what happened here. There is 2 reasons for these lesions to be embolic. One is the stagnation, and the other is the exposition of collagen and all the elements of the vascular wall. So here we have an occlusion just after the emergency of the PCOM, actually a fetal variant of the PCA. And then these are very typical interesting images of the GSA is still the golden standard for this. But non-invasive invasive imaging techniques are easier or even sufficient in many cases. Most common findings are this kind of hematoma, a crescent-shaped hematoma around the true lumen of the vessel. And it can be distinguished from the surrounding tissue with standard MRI sequences, for example, as FAT SAT T1 weighted sequences. And it's quite interesting for people who do radiology, because the signal inside the hematoma changes with time. It gets more hyper intense after some days, 3-4 days, and then it lasts up to 2 months. So the intensity of the signal here may even be a tool to state the age of the hematoma when you are in subacute phase. Here you have a CT. Actually, it's a CT reconstruction from a 3D angiogram. So as you know, most recent angio suites nowadays, they are capable of doing CT also. And then you don't see a clear wall hematoma here, but you see the flaps inside the vessels. Okay, and then here we have a typical dissecting aneurysm of the PCA after contrast was injected in the left vertebral artery. So some more examples. This is a postoperative pseudoaneurysm. It was developed after a skull-based approach. Was a voluminous cellular tumor, so it was treated endovascularly. These are recurrent lesions. Also, we're talking about a lesion for which there is a big fragility of the level of the wall. So vessel occlusion should be considered when possible. However, this specific patient, he did not tolerate the occlusion test, so we decided to treat it. And then, as you see, he recurred, and we had to retreat. And then in the bottom, you have typical images of also in the iatrogenic group, vessel perforations as contrast median. They are getting inside the cisterns, or sometimes drawing the anatomy of the pericerebral spaces, like sulci, for example. So of course, there's indication for immediate hemostasis. So a closer head injury, it's quite an infrequent region. It's up to 1%. Well, it may be even less nowadays, because even though non-invasive imaging is becoming very performant, we do not perform angiography as a diagnostic tool as much as we used to do in the past for non-vascular pathologies. So those lesions may not be perceived if you don't have a high level of suspicion. So an important fact is that we need to have this high level of suspicion, because even though it's less than 1%, we have a huge lethality rates, up to 50%. So those are fragile aneurysms. They rupture a lot. In the context of a head injury, this closed head injury was described as being more common in the pediatric population. And we have three main types that has been proposed. There is more than one classification for this. It's not the only one. But you can say that a true dissecting aneurysm is when you have intact adventitia. So you have the rupture of the intima, and you have the hematoma in the wall. A false aneurysm, you have all layers that are concerned. So you have rupture of the adventitia, and you have a flow that is around the vessel. So there is flow actually outside of the lumen, inside the false lumen, inside the perivascular hematoma. And then you can have a combination of this. And for evident regions, penetrating trauma, perforating trauma have been associated to false aneurysms, which are quite hemorrhagic lesions. So regarding the location, it's also very interesting. We distinguish two groups: proximal aneurysms and distal aneurysms, traumatic aneurysms. Proximal ones are related to fractures of the skull bases. So the vessels mostly affected, or evidently, the proximal carotid, infraclinoidal carotid, and the vertebral basilar system and proximal regions. And another possibility is acceleration, this acceleration mechanism. So with stretching of the vessel during the impact. And in this case, the lesion may be more superior, and related to the fact that you have a part of the vessel that is fixed to the skull base and the two structures of dura. And you have a part of the vessel above, which is very mobile. So this transition zone may be susceptible to stretching. So classically, the supraclinoid carotid. And then you have the distal group. And distal group, you have aneurysms of the branches of above the polygon of Willis, such as cortical and subcortical one. And so the mechanism here is different. Maybe direct lesion by skull fractures, or also indirect trauma by combining acceleration and deceleration movements with the impact of the vessels against the faults, the tentorial, or accidents of the skull, like the lesser sphenoid wing. So symptoms, they vary with location a lot. In the absence of hemorrhage, there is no specific symptom, but headache is almost invariably present when the lesion is intracranial. It means above the anterior clinoid, in the subarachnoid space. The explanation for this is the fact that we do have a sensory innervation, trigeminal innervation at this stage. And evidently, in the case of hemorrhage, the symptoms will vary due to the variability of topography. Epistaxis is an important point, it's an interesting observation. It may be the main or even the only manifestation of a traumatic pseudoaneurysms of the skull base when there is involvement of the carotid canal in the sphenoidal sinus. And another interesting point I'd like to stress is the timing of the hemorrhage, which is very peculiar. We have a very inclined, very sharp incidence curve, and the average time between the initial trauma and the aneurysma hemorrhage is really short, is less than 1 month. Those for us, the do endovascular, it's a big argument to treat these patients quite aggressively and quickly. So there are some elements that can raise a suspicion, like acute neurological deterioration, epistaxis, as I mentioned, repeated bleeding after an initial traumatic subarachnoid hemorrhage. And the traumatic subarachnoid hemorrhage, we do not necessarily investigate then initially. So I already commented the diagnostic methods, but there are some particular situations in which the rate of positivity of this examination is higher. That's the case of fractures of the carotid canal, evidently, and penetrating traumas that go through the ramification tree of the MCA or the cross midlines. So there are papers showing that in these situations, the angiogram may be abnormal and up to 38% of cases. So this is a provocative statement, because actually there's all cases that for which we should think about obtaining an angiogram initially at admission, even if the reason of the hospitalization is not vascular, it's trauma. But I think that most centers not done like this. So there are different combinations of treatment options, endovascular, surgical, and combinations. The endovascular arsenal has increased since the advent of flow diverters recently. It's certainly an important option when the goal is to preserve the vessel. When occlusion is possible, the therapeutic vascular occlusion should always be considered, in my opinion. There are highly hemorrhagic injuries, very recurrent, and that occur in patients that are victims of other traumas in other parts of the body. So preservation of a vessel is not always be the best option. In distal pseudoaneurysms, for example, non-eloquent injurient vein areas, a therapeutic occlusion would be many times the best strategy. So you have no stent, you have no flow diverters, you don't need antiplatelate, and then problem is finished. The same should be considered for aneurysms that are proximal to the polygon of Willis, and if the patient has a well-formed polygon with good anastomosis and has succeeded a temporary occlusion test. Of course, if the patient does not succeed a temporary occlusion test, the vessel must be preserved. So I have some cases to show you. So those are the same cases of the beginning. So this is a 32-year-old man was complaining of vertigo after aggression in a bar. He was fighting in a bar. And so you see, the only thing we had is this ischemia in the cerebellum. So this patient came into through to the neurology department, neurovascular unit. And then you can think, oh, there's something that's going wrong there. And then you see the angiogram, you do the angiogram. Many times we are asked to see those patients to verify, to check if they're eligible for thrombectomy, for example. And then you find a dissection. Okay, so there's a very interesting example too. It's a 39-year-old man, very athletic, sporty guy. He's a surfer. And he also works in the university. He's a teacher and a professor. And then he was complaining of a headache. He had some visual flashes, strange ones, memory troubles. And he was very precise, reporting that this started after a day surfing in the beach, a whole day surfing. And then he comes to the emergency department, once again through the neurology department. First, they did a CT scan, and they showed this. They saw this. So they started to discuss what was that. Was that an aneurysm? But it was not very opacifying. Some people even asked, "Oh, maybe it be a tumor." You see the artifact here in the TOF, the time-of-flight MRI, and you have an ischemia. And actually, the answer came easily with the angiogram. Actually, what he did, this guy had a temporal branch, a neurotemporal branch, was not that early, it was almost a trifurcation. And we saw that in the CT scan, this temporal branch was really close to, anatomically to the lesser sphenoid wind, just to the ridge at this point. So probably what happened is that he dissected this branch during his surfing session. He did the ischemia and a traumatic aneurysm, dissecting aneurysm of this artery. Actually, the aneurysm was not opacifying anymore. It was already occluded. He already did the ischemia. So the only thing we did is to finish to occlude this vessel just for security to prevent recurrence. This, once again, young patient, 22-year-old right-handed man, admitted after a car accident. He was the driver of a vehicle, what was really a high cinetic accident. He was intubated in the scene with a Glasgow Coma scale of 6. And we have this CT scan, that's the same I showed at the beginning, with the hemosinus and fractures not very far from the carotid canal. This is the brain window. You see that we have some hemorrhagic contusions. And he recovered progressively. Evolution was quite favorable. He had left 6 and 7 cranial nerve pulses, very discrete anesiochoria, was more dilated on the right side. And then he was transferred to a rehabilitation facility. Actually, you see the next, the end of the story. Probably this anesiochoria was Horner syndrome from the left side. But then what's interesting is 1 month and a half months later after the car accident, he started to degrade again. He had somnolence, headaches, some vomiting, and nasal bleeding. That at that time we didn't understand, people didn't understand the nasal bleeding. We didn't give much importance for this, but we did a CT scan. And then we found hydrocephalus. Okay, post-traumatic hydrocephalus. Radiologists were concerned about this lesion here near the temporal pole. Is this an old extradural hematoma or is it an MPEMA? So they did also MRI, so was not an MPEMA. Everybody was happy. Then he was treated with VP shunt. Everything was okay. In the first post-operative day, he was in his room and he presented 2 episodes of massive epistaxis, very different from the first one. I remember this with the rest of my life. I was in the corridor, they called me. It was very difficult to control. It was really arterial blood. And then at this time, angio-CT was done. And then you see these huge pseudoaneurysm, which was lodged inside the sphenoidal sinus, which was fractured at the beginning. And also you see when you have opacification of the ICA here, you see that the lower levels, you don't see the siphon, but you see both carotid terminations. And then we did the angiogram. You see very typical dissection at the left side, and the big pseudoaneurysm that is opacified by injection of the right internal carotid artery. And the internal carotid artery is taking care of both hemispheres because this patient had well-formed, very good polygonum. So there is no ischemia of this side, but in this case was a difficult one because for us it was impossible to treat this with vessel occlusion because the other side was already occluded. So we decided to preserve the vessel. We reconstructed the vessel with 2 concentric stents and coils, means that the coils were inside the sphenoidal sinus, and we had a good result. Of course, that flow diverters also would be a possibility here. We could discuss it. You have here the final result. So both carotid is filling from the right. There is a subtotal occlusion of the aneurysm. This is the control. So this is before, this is the control, 3D reconstruction, and you have at the control the artery that is completely endothelialized, completely reconstructed. So Now I'm just, I need just 1 minute to finish. I come back to the beginning. So we need an angiogram. So this was all of them are patients of trauma, but interestingly, the only patient that would not really need an angiogram in this panel is the one who has an hematoma. All the 3 other ones, they don't have hematoma. They don't have very important, voluminous intracranial bleeding, but they do have important vascular pathologies. So to conclude, since angiography is no longer a routine examination for non-vascular diseases as it was done in the past, we're doing angiography for a lot of things in the past, it's not the case anymore. The incidence of vascular trauma in closed TBI may be underestimated. It's true that non-invasive imaging techniques are very performant, but we need to think about vascular trauma. We need to have a high level of suspicion. And I think that it is not the end of the story, because there is so much development in minimally invasive techniques, such as endovascular, such as endonasal approaches. So I think we will still learn more about these pathologies in the future. So that's what I wanted to show. Thank you very much.
Yeah, excellent job, Igor. Although trauma is very interesting to me, your cases, all of them were extremely interesting and educative. So thank you very much. If there are any questions, well, I cannot see any questions.
Yeah, I don't see any questions.
Yeah, there are not much questions. So maybe I will hand it over to Ramesh to wind it up.
Yeah. I mean, there are some questions for the previous speakers. If you get a chance, just try and answer some of these questions. So they'll get the answers on the chat session. I think we've reached the end of the session today. I think it's been a great talk and all very illuminating topics, really. And I hope we have about I don't know, 460 participants all over the world, and also more so from the YouTube channel, very likely. So I'm going to ask Professor Imad Kannan to do the final conclusion.
Well, thanks, Ramesh and your team, Aipe and Kasadi, for moderating this session. It was a wonderful sessions. I'd like to thank all the speakers and the faculty for their contribution. I apologize for this technical issues. I think most probably internet issue with the sound for Dr. Schroeder, but as I mentioned, his presentation will be compensated later in one of these future sessions. So tomorrow we'll have an exciting day on orbital tumor and skull-base surgery, and I hope all of you will be part. And we are looking forward, because your feedback as a registrant and attendees is very important to tailor the future sessions for your education. I thank you very much, all of you, and stay safe and take care of your family. Thank you.
Will there be any evaluation links, Imad, for the participants?
Yes, yeah, we are trying to get the evaluation form hopefully by tomorrow or in 48 hours. One thing that's important from last time, we can give the certificate for people they are sending the evaluation form, because without a form, we cannot appreciate your input. And this is very important. And to do this, to give you the form, we need your email address. So try to get your email address to the registration, and you will get the form to fill it up. And in 1 week, we'll give the results, and you get your certificate from the World Federation Neuroanatomy Committee. I think this is the message. But thank you very much, and have a good night.
We do have the emails of everyone. Yes, we do have their emails, Imad.
We do have, okay. So
Already.
he's the boss. Okay.
Pablo, just to clarify, I think we're saying people should register, not just watch on YouTube, which is fine, but if they like the certificate and things, they need to register at the website.
Yes, but once those ones who are not registered, once they answer the feedback form, one of the questions, Igor will correct me, but one of the questions is email. So if they just fill it up, we will get it.
Great. Yeah, that's it.
Thank you very much to all HM group, gang.
Thank you. Take care.
See you tomorrow.
See you tomorrow.
See you tomorrow. Thank you for everybody and compliments.
Thank you. Tomorrow. Thank you.
Bye.
Sorry, can you confirm again what was the attendance?
See you tomorrow. Say again, Casadi?
Tomorrow.
The number.
We'll announce it later. So I think so. We
Sorry?
need to see tomorrow. You need the number. I think we will come to the number
tomorrow.
by tomorrow.
Okay, that's fine. Okay.
All right.
Excellent.
You are the host now,
All right.
Pablo. Pablo, you are the host.
Bye-bye.
Thank you. Bye, Vladimir.
Bye-bye.
Bye, Matt. Bye-bye.
Everybody.